Good morning. I am calling this roundtable to order. Today is Thursday, October 26, 2023. The time is 10:03 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. This is a hybrid meeting with government witnesses testifying in person and our public witnesses who will be testifying via the Zoom internet platform. Today, we'll be considering PR 25-0386, the sense of the council on the opioid and fentanyl epidemic resolution of 2023. This resolution urges the mayor to declare the opioid and fentanyl crisis in the district as a public health emergency, recognizing the seriousness of the situation and committing sufficient resources to safeguard the well-being of district residents. The opioid and fentanyl crisis has inflicted profound harm on communities within the district and across the nation and is widely recognized as a public health emergency. The crisis is characterized by staggering mortality rates, strain on the healthcare system, transmission of infectious diseases through needle sharing, adverse effects on families and communities, economic burdens, treatment barriers, and the largely preventable nature of opioid addiction. According to the U.S. Centers for Disease Control and Prevention, the CDC, the district currently ranks first in all drug overdoses and second in opioid overdose deaths per capita. Between 2018 and 2022, opioid-related fatality overdoses in the district more than doubled, from 213 to 461 lives lost. As of June of 2023, there were 238 opioid-related fatal overdoses in the district, and the city is on track to experience an increase from 2022. Alarmingly, more than 90% of the opioid-related fatal overdoses in the past 3 years were linked to fentanyl or its fentanyl analogs. Between 2017 and June of 2023, approximately 72% of all fatal opioid overdoses occurred among adults aged 40 to 60, and 30% of the opioid overdose deaths occurred among peoples aged 50 to 59. Overall, 85% of all opioid deaths were among Black individuals, and fatal overdoses were more common among males. The majority of individuals who died were district residents, and from 2017 to June of 2023, overdoses were more prevalent in wards 5, 7, and 8. I think it's more interesting to look at some of the FEMS data. So we talked about fatal overdoses, but overdoses in general, I think, are even more staggering. Throughout FY 2023, FEMS, which is the Fire and Emergency Management, FEMS, Fire and Emergency Management System, was called to respond to a suspected opioid overdose on almost a daily basis. In FY 23, FEMS responded to approximately 5,261 suspected overdoses, with emergency personnel administering Narcan in approximately half of those cases. The U.S. Department of Health and Human Services has already declared a nationwide public health emergency in response to the opioid crisis. Neighboring states, Maryland and Virginia, have also declared public health emergencies with regard to this. It is important for the district to do the same. When a public health emergency is declared in the district, it initiates a comprehensive response plan. This includes mobilizing vital resources such as funds, medical supplies, personnel, and equipment, possibly with the support of federal agencies. The declaration also fosters improved coordination among government agency, healthcare providers, emergency responders, and community organizations. It empowers the district to implement necessary policy and operational changes and heightens public awareness about the severity of the situation. In addition, legal protections for healthcare providers may be provided to allow them to practice outside their usual scope. The district may also set up temporary healthcare facilities if necessary. The declaration can also facilitate research and development efforts and provide access to federal assistance, including funding and expertise. Public health emergency declarations are typically subject to periodic reviews with the goal of responding effectively, mitigating the crisis's impact, and protecting public health safety. This roundtable coincides with the official launch of the Opioid Abatement Advisory Commission, the body which will provide recommendations for how the district will spend approximately $50 to $80 million it will receive over the next 15 to 18 years through opioid litigation settlements. The commission held its first meeting yesterday. The mayor will also release Live Long DC 3.0, the updated version of the district's plan to reduce opioid use, misuse, and related deaths before the end of the year. The Department of Behavioral Health will also open the first stabilization and sobering center in the coming days or weeks. According to DBH, the Low Barrier Center will provide individuals under the influence of alcohol or drugs with a person-centered care and recovery-oriented alternative to law enforcement response or to transfer to the emergency room. These are steps in the right direction, but it's crucial for the district to intensify its efforts to address the crisis to prevent 2024 from being another year of record-breaking fatal and non-fatal opioid overdoses in the district. All right, and with that, I don't see any of my colleagues who have joined us. So I'm going to move on to public witnesses. So the hearing will proceed as follows. So we will hear from our public witnesses first. Then we will hear from Dr. Barbara Bazaron, who's the director of the Department of Behavioral Health, Dr. Ayana Bennett, who's the acting director of DC Health, and Dr. Robert Holman, who's the medical director for the District of Columbia Emergency Medical Services. I said management before, false on my part. I know what the agency stands for. I want to thank all of them for being here today. And we're going to go ahead and get started. Okay, so we have 17 public witnesses who have signed up to testify. I think we're going to do panels of 7. Well, no, I'm going to do panels of 8 for the first panel, and then we'll do everyone else on the second panel. Okay, so that was for the staff to kind of know where we're going on that front. Ambrose Lane, who's the chairman of the Health Alliance Network, Heidi Ellis, the Advocacy League for Decrim Poverty, Queen Adedusi, who's the campaign organizer for Decrim Poverty DC, LJ Sislin from Decrim Poverty DC, Asaya Atimony, apologies if I pronounce your name incorrectly. I promise I'll get that correct when you let me know how to say it. Dr. Ocelia Pearsall, Shane Sullivan, and Javon Oliver. For those who haven't done a hybrid hearing with us before, you have to affirmatively accept our invitation for you to be promoted as a panelist. And before we get started on that front, I want to remind folks of the testimony guidelines. So witnesses representing an organization or an ANC will have 5 minutes to speak. Witnesses testifying on their own behalf will have 3 minutes to speak. If there are multiple people from the same organization, the first person who speaks will get 5 minutes. Everyone else after that will get 3. Great. Okay. I don't think Ambrose is here just yet. So Ms. Ellis, if you want to proceed.
I am here, council member.
Okay, Ambrose, no one was speaking. So Ambrose, why don't you go ahead and provide your testimony? Your
Okay.
camera is off, by the way. There you are.
Thank you. Oh, I'm getting an echo.
We can hear you. Ambrose, can you speak?
Yeah, mine is showing, my screen is showing two cameras. I don't know how I did that. Okay. Thank you, Councilmember Henderson. Yeah. Okay, let me try this again. Okay, so thank you, Councilmember Henderson and members of the DC Council. Thank you for the opportunity to provide testimony on this important matter. My name is Ambrose Lane Jr. I am chair of the Health Alliance Network. I am also a manager of the Opioid Solutions Working Group. The working group is made of 28 organizations and about 105 people, all committed to addressing the opioid crisis in the District of Columbia. The work that the working group has done for the past 2.5 years led us to we have not only created resolutions that have been passed by advisory neighborhood commissions over a two-year period. But we have also sent letters to the mayor and to the council chair regarding Narcan in high schools and in DC public schools, as well as Narcan made available in public spaces, especially in DC government. There's been a lot of work that and one thing that we promote health emergency. Yesterday, I attended the first meeting, and I have to say that even though they didn't work yet, I was encouraged by the abatement committee.
Ambrose, can you hear me?
Yes, I can hear you.
Your sound is going in and out, so we can't quite hear you.
Do you want me to log back?
Yeah, if you could log out and log back in, that would be great.
That's what I'll do.
Okay, we'll go to Heidi while we wait. Heidi?
Oh, sorry about that. I was on another call that ran over. I apologize. Good morning, everybody. 1 second. Multitasking today, so forgive me.
It's nobody.
Yeah. Can you hear me?
Yes.
Okay, perfect. Thank you, Chair Henderson and members of the committee. My name is Heidi Ellis. I work as a consultant advocate here in the district. I'm here today representing Decrim Poverty DC, DCPD campaign. DPDC is a grassroots advocacy coalition committed to decriminalizing poverty by working to end stigma, violence, criminalization, and other forms of oppression against people who are targeted by the state for crimes of poverty, including drug use, sex work, housing insecurity, citizenship status, and incarceration history. We're working towards a world where people are not punished for how they cope or survive and are instead met with compassion, systems of support, and dignity. I joined this work over the last few months. However, the advocates, folks with lived experience, and direct providers have been doing this work for years. As you know, the campaign, along with others represented here today, have been fighting to move the District of Columbia to formally recognize the overdose crisis through major investments, legislative advancement, to remove stigma and the criminalization of those in crisis, and to declare the overdose crisis a public health emergency. We applaud the council and specifically Chairperson Henderson for their support in these efforts and for introducing the sense of the council on the opioid and fentanyl epidemic resolution of 2023, and working with our campaign to create an even more extensive proposal to address the crisis and to make progress towards establishing 24/7-hour prevention reduction centers in the district, along with additional technical services and capacity building for communities and a workforce for sustainable change and impact. Although we applaud the council's efforts, we have been extremely concerned with the mayor's response to this crisis. Regardless of the overwhelming data, the countless testimonies from folks on the ground, and even urging from those in her administration, she continues to be inadequate in her response. We support this legislation and the rallying cry to declare this emergency now. We have been in a state of emergency for years, and this is not an issue that can be swept away by shuffling people around the city to clear out areas, or one we can wrest our way out of and further exacerbate the compounding issues. It is especially important that the council and the community apply pressure on the mayor to declare this emergency, as a conversation in the district around crime is taking center stage. And the mayor is proposing legislation to roll back the progress made in police reform measures established after the murder of George Floyd. Specifically, the Act Now Act of 2023 would allow the police chief to declare certain areas drug-free zones. This is deeply concerning, as we know these zones will be established through aggressive police tactics, including displacement and arrest, and will only be established to appease those with the loudest voices due to their socioeconomic status, who feel inconvenienced or unsafe by folks using in their neighborhoods. Additionally, we know this will disproportionately affect people of color in the district. I'm urging the council to scrutinize these efforts in the face of pressure due to fear around the perceived rise in crime. I'm going to be brief. I have others here that will speak more, and I'll submit a longer testimony, but I'll just close by saying I attended the inaugural meeting of the Opioid Abatement Commission yesterday. And although I was impressed by the conversation and the level of intentionality, I do urge Chairperson Henderson and the others of the commission to really heed the voices of folks with lived experiences. By law, there are supposed to be at least 2 appointed, and I believe we met that mandate. However, there is still an overwhelming sense of doing the same thing and expecting different results. So with this particular legislation for the emergency crisis, for this public health crisis, in addition to the work that the commission is doing, we're just urging that we move forward and reimagine how we address these issues. Thank you for this time, and I'm happy to answer any questions.
Thank you. Ambrose, let's try again.
Yes, I think that we're settled now. Thank you, Council Member. Once again, my name is Ambrose Lang Jr. I chair the Health Alliance Network, but I also manage the Opioid Solutions Working Group, which is a product of the Health Alliance Network, which is a working group of 28 organizations, more than 105 people, all dedicated to working towards solutions in the opioid crisis. We have been working since the May of 2021. So we've been working for 2.5 years on this issue. We have created resolutions that have been passed by advisory neighborhood commissions, as well as letters that we've sent to the mayor and to the council chair, trying to urge them to take certain actions in terms of addressing the opioid crisis. And I've testified on many occasions about this issue, but I want to point out some things once again for the record. Opioid deaths have risen every year since 2018, and the information that is now coming out of the CME's office indicates that there will probably be up to an 8% increase in opioid deaths this year over last year, which would make 6 straight years in which opioid deaths have had a record number in the District of Columbia. 2022 saw an average of 38 deaths per month, which is more than double the number of homicide deaths per month. The opioid crisis is killing more people than homicides. It is killing more people than COVID did. We have an epidemic that does not seem to be abated, regardless of the actions that have been taken by DC Health or Department of Behavioral Health. And I want to, first of all, laud the Live Long DC program as an attempt by DBH to address the opioid crisis. But with any program, there are going to be good points and bad points, things that work and things that don't work. Yesterday, I attended the Opioid Abatement Commission's first meeting. I was encouraged, particularly by the voices of those that had lived experience. It was actually refreshing to hear the voices of those that had lived experience weigh in on the opioid crisis and some of the things that have to be done. You had mentioned, Councilmember, that the CDC ranks DC #1 in all drug overdoses, #1, and ranks DC 2 in opioid overdoses per capita. We cannot continue on this path without a public health emergency. We held a press conference in April in front of the council building, urging the mayor to enact a public health emergency. Now the council is taking up a sense of the council resolution, again urging the mayor to enact a public health emergency. Why is this important? Let's try to look at it from just using the eye test. When you go to places like 16th and Good Hope Road, if you go to places like Minnesota Avenue across from the new DGS building, or if you go to places like North Capitol and P Street and other places in the District of Columbia, you will find where the opioid crisis is at its height. You will also find that when you look at the heat maps of where violence is occurring and where opioid deaths and overdoses are occurring, they are the same locations in the District of Columbia. So just use the eye test to see that we have an opioid crisis that is getting out of hand, despite the valiant efforts, I would say, by DBH in terms of distribution of Narcan, distribution of fentanyl test strips, a distribution of vending machines. All of those things are laudable, but they are not going to solve the crisis. And we need a public health emergency. We need leadership from this mayor to be able to enact a public health crisis, to do a number of different things that a public health crisis can do. So, for example, a public health crisis will allow opioid abatement money to be funneled into communities and community-based organizations at a quicker rate. It can bypass certain protocols that in procurement and other things. You can stand up brick and mortar. For example, we need to have 24-hour residential treatment for youth, 24-hour residential treatment for adults. We need an urgent care, behavioral health, and substance use disorder urgent care. We need a number of brick and mortar things that can be stood up within 6 months. So we can begin to greatly address the opioid crisis within a 6-month period of time if we so chose. There is space and land on New York Avenue that could replicate what is in Arizona in right outside Phoenix called the Zone, where you have 9 different agencies on a 40-acre parcel that is addressing the opioid crisis. The mayor needs to step up and call for an opioid public health emergency. Thank you for your time.
Thank you, Ambrose. I don't see Queen, but I do see LJ. Good morning.
Morning. Queen will not be here until 11, so just a heads up to everyone.
Thank you.
No problem. All righty. Hello, everyone. Thank you for the opportunity to allow me to provide testimony to the DC Council today. My name is LJ Sislin. I am a campaign organizer for the Decrim Poverty DC Coalition and an outreach volunteer and board member with HIPS. The opioid, fentanyl, and overdose crisis has been escalating for years. Lives are being lost, families torn apart, and the well-being of district residents is under serious threat. It is a crisis that warrants immediate attention, and I urge Mayor Bowser to declare the opioid and fentanyl epidemic a public health emergency. Drug-related overdose deaths are preventable. Part of prevention is meaningfully acknowledging that this is indeed a public health crisis, and then backing that statement with innovative approaches. We need political interventions that endorse, authorize, and fund harm reduction strategies. Ambrose has already mentioned a bunch of our statistics, but it continues to worsen every year. It is also notable to mention that this is also a racial justice issue, just as much as it's a public health issue. Alongside these devastating statistics, I approach you today with some solutions. Studies prove that criminalizing drugs and drug users leads to drug-related problems. Punishment and stigma don't work, but investing in drug user health, housing, and other social services does. The last place a person with a substance use disorder should be in is a cell. The trauma and record continue to negatively impact people when they return home, whether that be a higher likelihood of overdosing or getting access to safe and stable housing, social services, and employment. It also increases recidivism rates, and that just proves the inefficiency of jails and prisons' ability to rehabilitate drug use or drug-related behaviors. Criminalization is a great deterrent to the health and safety of our loved ones and interferes with a thriving community. Decrim Poverty DC's platform calls for the removal of criminal penalties for the personal possession of drugs. But we are also advocating for the authorization of 2 24/7 harm reduction centers with safe consumption services and comprehensive drug checking. These centers are proven to save lives and improve the well-being of participants in surrounding communities. For anyone who is uncertain about the efficacy of safe consumption services, I implore you to visit On Point NYC, which is the first legally sanctioned safe consumption site. It is a no-barrier safe haven with case management, social services, food, laundry, peer support groups, comprehensive mobile outreach, holistic healthcare, and community gardens. The centers are staffed by medical professionals and people with lived experience, which creates a compassionate, well-trained, and culturally competent team. The safe consumption services where participants administer their pre-obtained drugs is merely one of the many features and is located in a private room tucked away in the back of the first floor beyond the drop-in center. According to health workers at On Point NYC, most participants who choose to decrease their substance use and or enter more comprehensive drug-related treatment, they do so in that safe consumption room. I see that I'm over time, so I appreciate y'all calling us today for this roundtable, and I hope that we declare this a public health emergency.
Thanks, LJ. If you could stick around, I do have some questions. Asaya?
Good morning.
Good morning.
I want to thank you, City Council, and for allowing us to speak on the panel in reference to this. A lot of statistics have been mentioned prior to me speaking. I'm coming more so with personal experience with the issues of opioid and fentanyl issues. June of 2021, I got a call early in the morning to rush to my friend's house, Shakita McBroom. When I got there, she was hysterical and crying. The house was full of people assisting her. She's an ANC commissioner. She was an ANC commissioner in Ward 8. Her daughter, she went to wake her up for school and she was cold. And when she turned her over, she saw, foam in her mouth. And it was determined that it was a fentanyl overdose, poisoning. During that time, there were 2 other teenagers in the neighborhood who experienced the same fate. And I thought about the mothers because I've seen what my friend has gone through, and knowing how she gives back to the community and seeing the pain that she's going through with the loss of her daughter, with something like one pill, just one pill, took her daughter away from here. And I think that education this needs to be considered as a crisis, because we need to get into the schools and start educating the children about the severity of this. I run a life skills program in Ward 8, and it's called Rock Now. And in my class, I have approximately 22 young men and women who are at risk to gun violence or incarceration, or even worse, death. Many of them have never been on an interview. Many of them have never had a job. They are from the streets. And one of the things that I found with them, many of them would nod in class. And so I sat and spoke with them, and I asked them, I said, now, how can I get you on a job and you're high? What can I do, to turn this around? And they told me, they said, well, this is how we pacify our pain. A lot of them have been first responders to seeing their loved ones, their friends, people they've grown up with, since, the cradle, this, murder in front of them. So what I found was we have a lot of trauma in the streets, and we have a lot of young people who are indulging, in opioids because of that. This is how they're pacifying their pain. Also, 2 of my students last week, somebody sent me a video with 2 of my students who had administered Narcan to 2 young men at 16th and Good Hope Road who were overdosing. And at the time, from my understanding, one of them had no pulse or anything. But once the paramedics came, you could see he was moving and everything due to the Narcan. We have a crisis out here on the streets, and it's bad. I was on New York Avenue, and I had to I didn't have any Narcan on me because I was driving a rental car, but I had to do CPR to a young man who had collapsed at the McDonald's, and his lungs were filled up with fluid. I turned him on his side, something that I also learned from Ambrose and his wife when they did the International Overdose Day down at Check-It Enterprise. And I turned him on his side, and the fluid was just pouring out. You know, his friend didn't have a clue what to do. He was punching him, dragging him, hitting him. You know, education is vital in this issue, because you have new drugs on the streets like boot, stuff like that, which is a meth mixed with ecstasy. And a lot of the young kids are taking this. They're going to start adding fentanyl to this if they haven't already. And you're going to have a lot more deaths on the street. So I'm out here in the streets doing the work. I'm out here as an advocate. I see what's going on, where a lot of people who are behind the desk don't actually see. They're just looking at the statistics when I'm seeing it, you know, right there in front of me. So I definitely agree that this is definitely a crisis, and it needs to be addressed as one. And I'm hoping that the mayor would take heed to this. So I thank you for giving me the opportunity to speak.
Thank you. I hope you can stay for some questions. Dr.
Okay.
Pierce, thank you. Dr. Pearsall.
Good morning. Good morning. Thank you for allowing me to speak. My name is Dr. Ocelia Pearsall. I am a full-time combat veteran with 26 years of experience in substance use. Presently, I work as the program director for Prestige Healthcare Resources, which is a core service agency in Ward 8, as well as in PG County and in Baltimore. In the United States, more than 500,000 people have died from the opioid-involved overdoses since 2000. Research shows that 90% of all of those who have a substance abuse disorder started using drugs and alcohol before they were 18. Fentanyl now in the United States, according to the CDC, is a leading cause of death. Each week I encounter someone on the streets of the District of Columbia who is in need of fentanyl. Today, I am here to plead with the mayor to declare a public state of emergency. This state of emergency is vital because one of the benefits of declaring it will force the district to create a comprehensive response plan. That response plan has to include everyone. Currently, Prestige has partnered with the faith-based community to create and implement a trauma-informed care model to combat this epidemic, because people have to find safety in their own neighborhoods. It not only affects the person that's using, it affects their family members and the entire community. The time is now for us to stand together, not to just talk about what we haven't done, but to move forward about what we can do better. We know that some of the reasons that the fentanyl epidemic have become so great is because of overprescribing, as well as the demand for the opioids have increased due to self-medication. We've all seen the numbers of what happened during the COVID epidemic, and believe it or not, the numbers are on an uptick again. This is not just a district problem, this is a global problem, but because we are here in the district, we are begging the mayor and the council to do what is necessary. Remember, these children started before 18. We've already seen what happens with the age of people dying at the highest rate between 50 and 59. These are career users that now find themselves in a crisis, not of using more, but of using something that's deadly. Yes, people know about fentanyl, but there's some type of nuance that's going on that people still believe, not me. But I'm here today to say, yes, you and your child. We get cases every day where people had fake pills. They didn't know they were fentanyl, or they didn't think only one pill would be too many. Well, there's a saying out there that says 1 is too many and 1,000 is never enough. They're never going to get to the 1,000. They only take the 1. And so I'm just begging for us to start fresh and start new. Thank you very much.
Thank you. I don't see Shane. And I don't see Javon. Oh, just kidding. Mr. Oliver, I think, is attending in person. So join us at the table. Good afternoon. Good morning. I think our you have to turn on your mic.
Can we hear me now?
Yes, go ahead.
Good morning. Already in a rush to get through the day. Thank you for inviting me here, Councilmember Henderson and Marcia. Nice to see you. I just wanted to share with you all a approach that I'm planning on taking to resolve a lot of the crisis for the opioid crisis in the district. My name is Javon Oliver. I'm the executive director of the Olive Tree One Care. I'm the sole proprietor of a group of licensed practice of licensed allied health clinicians. We're a practice of professional counselors, therapists, social workers, marriage and family counselors. And yesterday, I was able to hire RN. We operate under the 1115 Behavioral Health Transformation Authority, Transmittal 1925. We are a group insured with 1 million per incident, 3 million aggregate malpractice insurance. I have provided my IRS W-9 forms and I've registered my ITIN with the IRS as the Olive Tree One Care Group. I'm a licensed professional counselor. I have my CAQH number and my national provider identifiers. This makes us an eligible group in the district to practice behavioral health treatment inside of the scope of our license. I'd like to make some suggestions as to where we should spend some of our opioid abatement money. As you're aware, last year, there were 461 opioid overdose deaths in the district. That's twice the homicide rate. Nationwide, there are 69,000 opioid deaths per year, and DC accounts for nearly 1% of all opioid deaths nationally. And something must be done to address this. I want to present DC government with the opportunity to put DC on the map as the nation's best innovative behavioral health care system. As you know, during the pandemic, the world learned a new way to take on challenges. Companies like Uber Eats, Uber Health, and DoorDash began looking at the elderly and those who were affected with COVID. And they began to build a bridge of IT to bring services across the social distancing gap and into people's home. The healthcare wasn't far behind either. During the pandemic, I was serving as the behavioral health coordinator at Department of Healthcare Finance. We created the healthcare telehealth policy, which allows the use of behavioral health therapy and services to be delivered across the world of various health information technology formats. And now we could use that technology to address the immediate needs for this opioid health crisis. Also during the pandemic, many people changed the ways that they work. Telehealth has become a routine way to access healthcare. At Olive Tree One Care, we found a way to use telehealth and behavioral health care to meet the district's needs of its most vulnerable population, children, people living with behavioral health and substance use issues. I've included 2 solutions to address the district's needs outlined in the tables. I would like to highlight the one telehealth solution to the opioid crisis. The proposed solution will cost less than a roughly used minivan. My proposed solution to address the opioid crisis is myself and my therapist. We plan to provide psychotherapy telehealth services to individuals experiencing an opioid use disorder. We plan to provide care coordination by meeting the individuals right at the hospital and allowing the telehealth service to begin, where we could perform an assessment right at their time of need. A lot of physicians at hospitals and emergency rooms are willing to prescribe Suboxone, an opioid treatment medication, but there's a fundamental issue. Without having a secure place to refer that individual to, most emergency room doctors are not willing to prescribe Suboxone. All of our FQHCs have the ability to subscribe Suboxone, and our care coordinators could set up that appointment for the individuals right while they're at the hospital, contact the health plans, schedule a Uber Health from AmeriHealth, AmeriGroup, and even MedStar. All of these are benefits that are available to the district residents, and then immediately connect them with a next day appointment and follow up telehealth visits while they continue to secure their Suboxone care. So that's one of the proposed solutions that we're looking at on utilizing our telehealth services.
Mr. Oliver,
Yeah,
sorry.
and I'm over time.
Yes, sir.
All right. I just wanted to address that with you. The rest is in my testimony.
Okay.
Please have a chance to look at it. Thank you again.
Thank you. And thank you for being here. Thank you to all of the public witnesses who are part of this panel. I do have some questions. I'm going to put myself on a 10-minute clock, Ashley, just to make sure that, oh, no. Stay seated. I'm going to ask some questions. I'm just putting myself on a 10-minute clock just so we can make sure that we can move along. And then, of course, if any of my colleagues join, just for awareness, there is another hearing that is going on at this exact same time in the Committee on Transportation and Environment. And so Charles Allen, who's a member of this committee, chairs that committee, so he won't be able to join us, but I know that some other members are going back and forth. Okay, so some questions. Ms. Asaya, if you're still here, I wanted to ask you a few questions. I want to say thank you so much for your testimony, and express my deepest sympathies for the loss of your friend's daughter. One of the things that we have been seeing in the data, and even from conversations that we've had with Children's National, is that even though the bulk of our overdose epidemic issue in the district is with older men, that we are seeing an increase in the number of young people who are also overdosing as well. And in some cases, maybe not fatal, but still certainly happening.
Definitely.
You spoke a lot about the need for increased education. How do you suggest we deploy that? Is that in a health class? Is that a supplemental something after school? It's been a long time since I was 15 or 16. So, you have more conversations with the young people, with your students. How would they best receive the information?
I think in the schools, most for sure. You can do plays, things like that. Because I've been thinking about that. Some plays, where you see, to make it real life. Because a lot of the kids, they're taking Percocets and things like that, and it's being given to them by a friend, and all it takes is for them to get a hold of a pill that's laced with fentanyl. And, and the friends will leave them right there because they're terrified when they see them drop, not knowing what to do. And this has happened in many cases. So I think that education is vital. It needs to be in the schools, after school programs, what have you. I've been teaching in my life skills course, and we're talking about young men and women who are indulging in the drugs, and a lot of the stuff they didn't even know. They didn't even know that it attacks the kidneys, the constant use of taking these pills and things like that. They didn't know a lot of the stuff that I have found out, and I presented to my students because I saw that it's a problem, and I'm like, how can I send you on a job and you can't even sit in class without, nodding, and it's sad. It's sad to see how young people like this. And then when I saw that you have a new drug, hitting the streets, it's sweeping the streets. The young people, they're taking this boot And because it's a meth involved, it's highly addictive.
What is
Highly,
it?
it's terrifying.
What did you say it was called?
It's called boot.
Boot.
Yes.
Okay.
And it starts to decay the teeth really fast. It starts to the appearance changes quick. I've been seeing it. I'm like, what's going on with so and so? You know, as I'm walking up and down the streets, you know, checking on everybody, and I'm like, well, why is he looking like that? And he's like, it's that boot. And I'm like, oh my gosh, this stuff. I'm like, I'm shocked people don't even know that this is out here, but it is really bad, and it's hitting our communities really fast.
Yeah, I think that you bring up a really excellent point in terms of sometimes the communication or the education doesn't need to be a teacher in front of you at a classroom providing it, but rather a more interactive thing. I think about when I was in college and I was on the orientation staff, and we would do these quote unquote skits to help the freshmen about, like, you know, you may not want to drink excessively because of X, or, you know, having conversations about consent and, you know, all of these different things. So that might be an interesting way to do it. But also, and I think I've brought this up before and that everybody laughs, but like, I'm a kid who went through the DARE program. And while DARE definitely had some issues, nonetheless, it definitely got into the schools around, you know, education and those kinds of pieces. And frankly, you just introduced us to a new drug, because a lot of times we learn about it from the OCME when they do autopsy reports, or they do tests, or the public health lab does testing on needles. That's how we learn about the new drugs that are on the street. And so now we kind of have a new one here. So thank you. Thank you for, go ahead.
You know, one of the things that I meant to mention to you, and this tells you about the lack of education that's out there. When the gentleman collapsed at the McDonald's, and I was like screaming, who has Narcan? Nobody had Narcan. The manager of the McDonald's came out, which is right across the street from DBH. And I said, do you have Narcan? And she said, no. I went home, bagged up Narcan, took it to them, gave her a crash course. Her and the assistant manager gave them a crash course. And I gathered up the gentlemen, the men who were out there with the guy who collapsed. And I said, this could be you next time. And I gave them a crash course, and I sent them off with Narcan. It is important that we get this information out here. I mean, you know, Narcan can save a life, you know, and it's unfortunate that this McDonald's, they had not even a clue. They didn't even have Narcan at hand. I was just, you know, so upset. I was upset with myself because I didn't have it, because I'm driving a rental car. So I usually keep it in my car. I didn't have it in my, you know, on me. I was just really upset. But I did administer CPR, and, you know, he's fine.
Yeah, I hope you don't blame yourself in that regard, right? It is not a responsibility of one person to provide Narcan for everyone in the community. And it just is incumbent upon us to make sure that it's more widely spread available. But you said in your testimony, and Ambrose, I see that you have your hand up. I want to bring you in on this conversation, that you and your wife had been hosting trainings at I believe it's the overdose prevention day that you did. Is this something that you guys do regularly? And is it something that we should be doing regularly?
Yes, as a matter of fact, yes, both me and my wife, especially my wife, in the organization she works for, does regular Narcan trainings. They just had a Narcan training last week. But let me say this too, and this is part of the opioid crisis, why there needs to be a public health emergency. And this ties in the Abatement Commission, because the DBH had a Live Long DC meeting yesterday, and I attended that meeting as well after, and I actually sat next to Asaya. And so the conversation came up about communication and outreach, and I raised the issue that there needs to be a more robust communication in public education campaign around this issue. It's not just being able to go into schools or doing skits, because I've worked with the Children's Legacy Theater. At the event that you mentioned, council member, I had the Children's Legacy Theater do a skit on opioids. And we had over 100 young people at our event. And we had involvement by Dr. Moise and others from DBH. In other agencies and other organizations. So it can be done. The education can be done, but it needs to go broader than that. It needs to go to television. I know that there are some spots that Dr. Bazran has done I was told that those aired late at night, like 1 and 2 o'clock in the morning. But there needs to be more tailored TV ads that appeal to young people. And I could work with ASEA and other organizations. I spoke directly to Mike Bento, who is the Live Long DC person doing communication, and they have billboards, they have bus placards, they have a number of different things. But one of the things that they don't speak to is the danger of fentanyl and the danger of opioids. They certainly have bus stop signs that talk about, bus stop posters that talk about where you can go to get help. Those are important, but you also have to reiterate how dangerous fentanyl is. One pill can kill. One time can kill. We have not scared straight. The scared straight doesn't really work, but education about how dangerous it actually is, and to be wary of taking drugs from people that you don't know, wary of taking or even taking pills from friends. You just don't know. And so these are the things that we're talking about.
Yep. Ambrose, I think you bring up a really good point. You know, when I think about some of the ads, PSAs that we saw deployed around tobacco, you know, this is what the insides look like, or you will have this type of lung damage, or, you know, veered on scared straight, but nonetheless also providing a visual. I think too, it's not just about notification to the students, but also to parents, for many of whom think that like, oh, well, I don't see any marks on my child, so that perhaps it's not happening. But, you know, for folks to know that fentanyl is colorless, right? It's odorless. It could be deployed on anything. I think that we definitely need to do a better job from a PSA standpoint. I'm running out of time, but I'm going to break my own rules here. So LJ, if you're still with us, LJ, I appreciate your testimony and obviously the work that you all have done with decrim poverty. I wanted to let you know that I did go to On Point this summer. We went to both locations, my staff and I, and also a staff member from Councilmember Parker's office. And I thought it was incredibly impressive in terms of what they have been able to do, but it also requires a lot of on the ground work prior to, which is something that On Point did, right? They did a lot of public safety and targeted outreach prior to opening any of their centers, and also building trust with the community in terms of, if you see something, here's a number that you can call, and you know that somebody is going to be there within the hour to help or to clean up needles or to do other things. I thought that was probably like their public safety and outreach operation, I thought was highly impressive. And for those who don't know, On Point has approximately 35 staff who they hire just to do public safety and outreach. And their teams are deployed in 3 shifts starting at 6 a.m. And I feel like, given some of the things that we are starting to see here in the district, we might need that type of operation. I was curious, and I see Heidi as well, if you guys want to come into that conversation and sort of provide some thoughts on that.
I'll defer to LJ first, but definitely.
Okay, and what was the last part that what was like the specific question?
Your thoughts in terms of the public safety outreach portion, right? So, you know, not just the outreach to individuals who are users, but outreach to the community members who are also impacted, so that they know, you know, if something happens, here's a number to call. I thought that was, we had a couple of instances here in the district where, you know, we had a school who called because they had needles on the playground, but they didn't know who was the person to call to have them picked up. Or another instance at an elementary school where someone overdosed on the front steps of the school, and the individual was still there when students were arriving. So like, there has to be this other type of network of support outside of law enforcement who is doing some of this work, outside of law enforcement, outside of DPW, outside of the custodians at schools and rec centers. I just wanted to sort of hear your thoughts on that.
Right. So I do want to mention that currently, as it stands, HIPS does provide services like that. HIPS fields questions from local community members, from schools, faith leaders, We also do a lot of Narcan trainings. We're doing a Narcan training for a group that does tenant organizing. We do Narcan training at churches frequently. It's very common for us to be mobilizing around the communities and having community conversations. That's part of what we say when we say meeting people where we're at. We're not just talking about people that are using drugs, people that are experiencing drug addictions and or incarceration, or like some of the worst things that can occur to someone. We're talking about the entire community. That could be a loved one, a family member, or someone, a concerned neighbor. It can also mean someone who's like, hey, I live in this apartment. There seems to be needles and like discarded syringes, and it might be someone who's just confused about what's going on. We also provide education and information specifically on the hotline. So I do just want to boost the HIPS hotline. You can find the number online. You can just HIPS DC, it's on there. So that is an availability. That is something that's available. I believe, I don't want to put this on the record, but I believe that Family Medical might do similar things. There are other orgs that do services like this. I will also say that as much as I want to continue to boost the amazing work that everybody is doing, everyone's burnt out. It's an incredibly stressful environment. The labor itself is difficult. And then you add on the fact that many people have lived experience. So they're getting re-traumatized consistently. We don't have a lot of infrastructure for people to be able to take the breaks that they need. And even if they do take the break that they need, we don't have the right infrastructure in place for there to be plenty of labor force for them to still be providing outreach. And
Right.
Consistency, as I mentioned, often consistency is key.
LJ, how many
seeing the same
people?
faces.
How many people do you guys have on the team?
Mobile services have they expanded recently, but I think they've also decreased. I'm gonna say it's maybe 6 or 7 folks.
Okay, so 6 or 7 folks for the entire city.
The entire city.
For your organization.
For HIPS.
For HIPS, but still, right? When we're talking about the numbers of what we're seeing, 6 or 7 people for one organization, I can't imagine that Family Medical Services has, more than 10 who are sort of doing this work as well. You have Miss Asaya who's kind of doing it out of her organization, a lot of piecemeal pieces, as opposed to the larger coordinated effort I feel like that this crisis requires. And that's kind of what I'm trying to get at. I think my staff laughs at me, but I say for DC, we are resources rich and we are coordination and implementation poor. Oof. And on this particular crisis, we have to be better in terms of that front. Now I'm way over my time because it's now 11 o'clock right now. And I've only talked to 8 of you. Dr. Pearsall, thank you so much for being here and for your continued advocacy. Mr. Oliver, thank you so much for the work that you are doing and the work that your organization is doing as well. We need more clinicians. We need more organizations. I think that if we on the streets are reviving someone and then we have no place for them to go after the fact, or the continuity of care, right? Whatever the particular handoff is, if it's from you receive some treatment while you are in the custody of BOP or DOC. Now, when you come back out, what are we doing? And if it takes 2 or 3 weeks for us to get you connected, those are opportunities for relapses. And I just, again, not really coordinated in terms of okay, let's think about this in a more systematic way. But I want to thank everyone for their testimony. If you haven't uploaded your testimony online, please do so, because we want to make sure that we have a record, that we're building a record on this, which is why we held a hearing on this since the council resolution, even though we could have taken it straight to a vote for the council. So please send that information on. So we're going to move on to the second panel. We have Dr. Edward Chapman, Mr. Larry Bing, Dr. Beverlyn Settles Reeves. Saw all of these people yesterday. John Domobrowski, Commissioner Jamila White, Wilhelm Bonnet, and again, I'm calling everybody else who's on the witness list. Anna Jones, Elizabeth Stahl, and Michael Pickering. So for those who are currently in the Zoom, you'll be moved back to a general watch, and then we'll have the next panel come up. She just add her to the room. Okay, Dr. Chapman? Dr. Chapman, I see you. If you're speaking, you're on mute.
Morning.
Good morning.
Thank you, Councilwoman Henderson. I'm Dr. Edwin Chapman. I've practiced medicine in the District of Columbia for the past 50 years. I've treated opioid use disorder for the past 23 years. Are you getting the feedback?
We are getting a little bit of feedback. Yes, sir.
Okay, is that better?
I'm not sure if you are in a room with somebody else who has this on, but they probably. Okay. Dr. Bramaninski, can you mute yourself?
Is that better?
Yes.
Okay. I've practiced substance abuse disorder, opioid use disorder for the past 23 years. Ran one of the 3 current methadone clinics for 12 years, and used office-based buprenorphine for the past 18 years. As Mr. Oliver pointed out, my office was a pilot demonstration project beginning in 2015 for the telebuprenorphine mental health platform currently being expanded across the country. I've given talks from coast to coast. Never in my experience have I seen a situation as bad as it is right now in the District of Columbia. For the past 4 years, we've suffered with open air drug market in the parking lot in my building. Numerous, too many murders to even count within 2 blocks of my office, overdoses, etc. I've been on the forefront of medication-assisted treatment, advocating for dosing changes for buprenorphine through pilot studies with the Howard University College of Pharmacy, initiated 7 or 8 years ago, and now being widely accepted as valid. Again, last year, for the first time in all my years, we had 3 patients on separate occasions to overdose in the office. Those patients each required 6 times 4 milligrams Narcan to be successfully resuscitated. And those 2 of those patients are still alive today. We've advocated in some of my talks the use of doubling the Narcan dose to 8 milligrams, and lo and behold, the federal government and researchers just introduced nalmefene, which is not naloxone or Narcan. It's delivered in the same manner through a nasal spray, but it lasts longer and works fast. And again, we are in the District of Columbia now at 100% fentanyl. Every patient in my office that tests positive for an opioid has fentanyl. We rarely see heroin. For the past 3 weeks, my laboratory has started testing for xylazine, and we've had 16 different patients to test positive for xylazine in addition to fentanyl. So we're beyond crisis. We're 7 or 8 years behind in our implementation of state-of-the-art practices. Hopefully, by being a member of the Opioid Abatement Committee, we will be able to move much faster and get services to deep into the community. But we're losing patients. I just looked at the last overdose report from
Dr. Chapman? Okay. It looks like his screen has froze. So I'll just give it a second. Okay. Dr. Chapman, are you back?
yes, I'm here.
Okay, your screen froze, so we didn't actually hear the last bit of what you said.
Oh, I'm sorry. So I just looked at the medical examiner's latest statistics through July, and at the current rate, we are projected to have over 500 deaths this year. I'm going to stop there.
Okay, we'll have some questions. I just want to note for those who are testifying, we've been joined here in the council room by Councilmember Zachary Parker from Ward 5. Councilmember Parker, I'll turn to you once we're finished with this round of public witnesses. Okay, Mr. Bing? You're on mute, Mr. Bing.
Well, I think, okay, now am I
Yes,
all
sir, we
mute
can-
now?
Yes, sir, we can hear you.
Good morning, everyone. Good morning, Councilmember Henderson, Ms. Huff, Dr. Chapman, and those who are on the platform. Like stated earlier, my name is Mr. Bing. I work for Leadership Council for Health and Communities. I'm a prevention navigator, and I work through Dr. Chapman's help on the telehealth platform. I heard Mr. Oliver mention that earlier. Since doing this work, I have learned a lot, but I think I know this is about the opioid crisis and trying to get the mayor to declare it as such. I am on the abatement committee also, and I was downtown yesterday, and I want to use the word hopeful because I am hopeful. But I was a little disappointed. I'm not going to say that I wasn't. There were some things that I didn't think went well. But I guess moving forward, we can always do things better. I just want to say that I think that we need to. I was listening to the young lady earlier when she was talking about someone that she know had died. Doing this work, my wife and I, we've lost clients as well. It's painful, but the seriousness of this is what we need to really focus in on, because I know that we're trying to get the mayor to do a thing, but even if she doesn't, we have to do our parts continuously. I don't want us to lose sight of that. I know we want her to, call it a public health emergency, crisis, whatever words we choose to attach to that. But let's not lose sight of what we need to do Monday through Friday, Saturday, Sunday, whatever day, whatever hour, we need to continue our platform and make sure that the work that we're doing gets done and continuously try to reach clients. Because whether they're young, middle-aged, or old, people are dying. And Dr. Chapman has just pointed out the data surrounding this. Somebody else had brought up a new drug. Every time you turn around, there's a new drug on the platform. I don't care whether it's boot, xylazine, fentanyl, whatever it is, it's coming. Because one thing that we have to realize, drugs have been here, will always continue to be here. That's something we're not going to ever get rid of drugs. But the thing is to try to combat it as well as we can with prevention, telehealth, and those things that we have in place. And that's why I mentioned of not losing sight of what it is that we're doing. I too want the mayor to call it what it is, but even if she doesn't, I'm not going to stop doing what it is. We do Monday through Friday, trying to help our clients. I know that you heard me, Councilmember Henderson and Ms. Huff, y'all heard me speak to the generic medications and certain other things that I think we need to address as well. And I'm not
Yes.
going to take up a lot of time because
Well,
these things
you're
are
over your
important.
time, Mr. Bing.
Okay, go right ahead. I'm
All
sorry.
right.
I'm sorry.
No, it's
Okay.
okay. I know sometimes people don't necessarily see the clock. I don't see Dr. Settles Reeves, but I do see Dr. Damabrowski. Did I say that? We cannot hear you. No, sir. No. All right. Why don't you close out and then come back in? Okay. And we will go on to the next person that I do see here, which is Elizabeth.
Hi, thank you to the council and thank you to Councilmember Henderson and Councilmember Parker. I'm speaking as a parent and a resident of Ward 5 to document for lived experiences of my children who have been impacted by the mental health and addiction crisis we are experiencing as a community. I also just wanted to acknowledge my daughter was one of the children that witnessed the brutal attack by the Petite Scholars toddler class on S Street. And I really do want to urge our community, I'm sorry.
Okay, take your time.
To protect our truly most vulnerable, our babies and our children. What happened was unacceptable. On that note, I do want to document 3 things that did happen at the Mundo Verde JF Cook campus, where my son is in pre-K. On the week of September 19th, multiple fentanyl containers were found on the school grounds, and toddlers, children in pre-K 3 and 4 brought them home and into the classroom. Additionally, on September 27th, as I was picking up my son from aftercare, a man brandished a gun near the campus, and I was put in lockdown with other parents. This school handled it beautifully. And then finally, the week of August 31st, in another drug dispute at 8:30 in the morning, a man was stabbed near the school, and the victim ran to parked cars, bloodying them as he tried to escape the attack. I know this is an incredibly complex issue and we cannot police our way out of it. But I urge our community to protect our children. And I will end on this. I know some people will call for more criminal justice oriented solutions, but I really want to urge the council and the city and our mayor to better coordinate and connect our community with stakeholders and resources in the community. If we can build a consistent and reliable and trustworthy mental health and substance abuse support service, we will not only keep our children safe, but keep our community safe. Thank you.
Thank you, Ms. Stahl, and thank you. Thank you for being here in your testimony. If you can just wait a minute, and we will ask some, I'm sure we'll have some questions, but I do want to share, well, we've talked. And so, yeah, I will just say that.
I do have to run to a work meeting, unfortunately, so I
Oh,
can't
okay. Well,
stay.
no.
But I thank you, everyone, and I really do urge everyone on this call to make sure that, I mean, my daughter's only 22 months, and all of her classmates witnessed the brutal attack on her teachers. So please, please protect our children. Thank you.
Thank you, Elizabeth. And we are definitely working on that particular issue. And we've been in contact with Petite Scholars to provide some additional supports there, as well as to Mundo on other issues separate and apart. Dr.
Dombrowski, I think you can hear me now.
Yes, I can hear you
It's
now. Yes, sir.
It is difficult. So again, I want to thank you very much, Councilman Henderson, for this opportunity to speak with you. My name is John Dombrowski. I'm a physician. I was born in Washington, D.C. at Georgetown University and actually went there for medical school. I did my anesthesiology training at Yale. I'm board certified in anesthesiology as well as pain medicine and addiction medicine approximately 5 years ago now. I want to approach this maybe from a different perspective than everyone else would. They do have certain values in terms of poverty and jails and things like that. I want to approach this as a physician. What are we going to do medically currently? Because right now we're just using, gum and duct tape to put things together. And I really agree with what you said with respect to, we've got a lot of resources, but there's no coordination of care. And that's the biggest problem that I see. I mean, right now, I run 4 methadone clinics, an addiction practice, as well as a pain medicine practice to get people off medication and actually help them medically with their initial problem, which is a pain issue. But with that being said, right now, there's no coordinating of care. And right now, we've got all the Narcan going on at $150 a pop. I mean, that's great for that moment in time. Or we've got buprenorphine going on. Oh, that's great. But where's the coordination of care between what we're talking about, the services? I think Ambrose Lane had a really good point, what they did, and I've worked with him in the past with respect to, coordinating care like on New York Avenue, like they do in Arizona. I think that's a great idea. But more importantly, let's approach this from a medical perspective. What can we do better? Right now, it's shampoo. It's wash, rinse, repeat, and hoping for a different outcome. And clearly, we're not seeing that. Everyone's got all the methadone out there. Everyone's got the buprenorphine out there. And rates go up, up, and up. Let's do something different. And so what that would be is like, look at each patient and not say that, well, the bigotry of a low expectation, well, it's poverty, it's this, it's that. No, they're human beings. They need to be treated as such lovingly to say, we can do this, but what is medically going on with you? And again, a lot of these patients have undiagnosed depression, other mental illness disorders, and they're filling up this hole with drugs. So let's fill it up with something better. So again, I've worked with Dr. Chapman. Again, let's look at genetic testing on these individuals. Is there something genetically different in these communities that they're rapid metabolized or slow metabolized? Look at it from a scientific perspective. Let's look at other medications that couldn't be diverted or misused, such as buprenorphine can be diverted or misused, or methadone or other drugs as that were. So look at medications like, instead of giving someone nasal Narcan, naltrexone, that lasts for 15 minutes, which is great. How about implant therapy? Or how about injection therapy that lasts for a month, or maybe an implant that could last 6 months? So we're going to look at this problem from a different perspective, because clearly what we're doing now is just not working. And perhaps, again, I might be a heretic on this, to ease your access and all that sort of stuff. And maybe there's a way of, transitioning those people from, illicit drug use to sobriety, which is great. But that should be the overall goal. And again, this is a big package. So it's an umbrella with respect to, our children that we have to talk about. Again, if we can prevent them from getting, drug use early on, that's really key, because the brain is very plastic. It doesn't really form until you're like 25. So I really think this is a great opportunity. I know the district and the council, and I know the mayor is going to do the right thing, but I also want you to understand that this is a medical issue and should be really treated as such versus a psychosocial issue. So I think medicine really has a role, and physicians with this certain skill set, as an anesthesiologist, as a pain medicine physician, as an addiction physician, really have the skill set to really move this forward. I thank you for your time.
Thank you. Mr. Pickering.
Good morning. Thank you for inviting me. I'm Michael Pickering. I'm the Director of Advocacy for Rep Cadencia here in DC. We are the longest serving SUD and mental health provider in the district. I've been watching the Roundtable since the beginning, and I have to say I am overwhelmed with the talent that we have in our field. It's crazy to me that we are actually having this conversation, that we have not declared a public health emergency. It is, sorry, something just popped up on my screen. I think I lost you.
No, we're still here.
But I really don't have anything to add. I mean, people far smarter than me have already said all of the important things that need to be said. We fully support the resolution. I promised Marcia that I would stay under time. So I have submitted my written testimony, which I timed out at 11 minutes. So I'm happy to answer questions, but there is such a valuable, talented pool of providers in this community, and we need to all come together.
Thank you, Michael. And stick around, we do have some questions. I know that was the last of the printed agenda, but Queen, who was supposed to be on the first panel, has joined us.
Good morning, Councilmember Henderson and other council members present. Am I able to start testifying?
Yes, go ahead.
Great. Hey everyone, my name is Queen Adasui. I'm a proud resident of Anacostia. I have lived in DC for over a decade now. I've testified before this body for years on issues related to DC's drug policies, harm reduction, overdose, and the harms of criminalization. I'm here first and foremost to thank you for this resolution. As you know, advocates have been calling for our overdose crisis to be declared and treated as a public health emergency for years. This crisis has been a crisis for years now. I don't need to repeat the statistics that have already been mentioned and that folks are already familiar with, but I want to use my time to be clear that the overdose crisis is very clearly a public health emergency in the same way that we all know that water is wet. In addition to declaring this very clear emergency, I implore you all to please take swifter steps toward the solutions that we have been asking for years now in order to save and improve lives. In order to treat drug use like a health issue, we have to stop criminalizing drug use and personal possession. Even more so, we have to immediately move to establish 24/7 harm reduction centers that include safe consumption, as we have seen these centers being an effective and compassionate hub with a multitude of services that actually save people's lives. In the first year of On Point's opening, they intervened in more overdoses than the total number of community members that we lost entirely to overdose at our worst rates. And even more, they are able to intervene in overdoses far before Narcan is required, compared to our realities of people being discovered experiencing an overdose and needing to be pumped with Narcan. Getting this right is important, but we have to get started. People are dying from preventable deaths left and right and have been in our city for years. I was privileged enough to attend the Drug Policy Alliance's conference last week in Phoenix and met several advocates from across the world who have been responsible for opening up overdose prevention centers in different countries. And the results are indisputable. We don't just have New York as an evidence or case study. Please do not get bogged down in stigma and fear. Help us save lives by declaring this emergency and also investing in the evidence-based practices that prioritize drug user health and safety. I want to also name that our collective goal should be to save lives and improve the lives of people who use drugs by meeting them where they are with love and compassion and in preparation to address all of their needs, not simply focusing on the unrealistic goal of ending drug use entirely, because that does not work for everyone. Our drug supply is just too adulterated for us to not immediately invest in drug checking services and a safe consumption program. I want to amplify what was said earlier, but it's unrealistic to believe we can disappear drugs from our society. If that was possible, we would have a drug-free world as it is, given the decades of drug prohibition and drug law enforcement that we've experienced in our city and across the country, and frankly, across the world because of the ways that we've exported the drug war to other countries. An unrealistic goal of a drug-free society cannot trump our goals of saving people from accidental death, meaning we have to focus on education that isn't just abstinence-based. We need more drug checking services, and we 100% need a center that allows for safe consumption. Help us get there. Thank you.
Thank you. And thank you again to all of the witnesses on this panel. Dr. Chapman and Mr. Bing, I want to say here, I appreciate your willingness to serve on the commission, where I feel like we have some further conversations around, some of these pieces. Michael, I wanted to ask you, as you are, your organization has been around for quite a few years, sort of in this work, and then also working with associations and things like that. Do you feel
53 years?
53 years. Do you feel like it's possible to get to the higher level of coordination that a lot of the public witnesses have brought up in terms of, when someone is at the stabilization center and they are stable, or they're in an emergency room and they get stable, to be able to do the direct handoff that enables for someone when they are ready to seek treatment to be able to do so?
Yes, we actually do that. That happens. It's been happening for, well, I've only been around 22 years. So, but it happens. We refer, we step down, we step up. That's
right.
work.
So you're saying it's happening, but clearly we still have a crisis on our hands. So what are some suggestions around how do we improve that?
We need to eliminate the silos. I mean, we're said the intended vision of the integration of the old APRA with DMH to create DBH was that we would eliminate those silos, and that actually has not happened. We do still have a bias between mental health and substance use disorder, and that hurts our patients.
Yeah.
And we're moving into managed care, and they're still trying to figure it out too.
Right. That's not the subject of this hearing, but it will be a subject of future conversations in terms of what that carve-in looks like to make sure that it is seamless for patients, providers, and for the MCOs alike, in terms of the work that's going to happen there.
And I will just add, all of the MCOs, all three MCOs, have been very receptive to how we're going to make this transition, and working with the community providers.
Great. I don't have any further questions. I do just want to mention for Queen, as you weren't here earlier, I told LJ that, my staff, myself, as well as staff from Councilmember Parker's office, did visit On Point this summer. And so, we have some complications here that other jurisdictions don't have. And so I think we have to, open to innovation and evidence-based practices, but we have some limitations of what we can do. And I don't want a situation for us going forward, as we're sort of trying to combat this opioid crisis, for congressmen from Louisiana or Oklahoma to handcuff us before we even get started, which is what we saw happen in the 90s in terms of needle exchange and some other things that has put sort of DC, it already started us sort of slow going. But with that, I'm going to, like I said earlier, we've been joined by Councilmember Parker. Councilmember Parker, we'll have 10 minutes for both your opening statement and for some questions for this panel.
Thank you, Councilmember Henderson, and thank you all for sharing your testimony. I will be brief in terms of my opening statement. I still remain very concerned about the opioid and fentanyl crisis facing the district. As Dr. Chapman said, it is routinely said that this is the worst that many folk have seen and that our city has seen. And so I'm fully supportive of this sense of the council. I believe it is well past time that we declare our opioid crisis as the public health emergency that it is. And what I'm really interested in hearing from our government witnesses, but also some of you about is how do we perfect that coordination that we so desperately need? Before I go there, I did want to just also acknowledge the heart-wrenching testimony from Ms. Stoll. And I imagine the many parents at Petite Scholars that may be tuning in or paying attention. As the Ward 5 council member, we have been working around the clock all week. I also want to acknowledge the tremendous work of Dr. Bazran at DBH and her consistent commitment to working with us, working with Councilmember Henderson to make sure that teachers and children there at Petite Scholars get the support they need. But we acknowledge more needs to be done. And so this is just the start of the work. But what I've seen today, or this week rather, is a demonstration of the coordination that we must see from community providers, government, elected officials, and the like. But my heart continues to go out to all of the young people that undoubtedly were traumatized by this week's events. And so with that, I will turn briefly to questions. And I would start with Dr. Chapman. Given your expertise, given your participation on the Opioid Abatement Commission, and I'm really excited about that, by the way, what coordination do you want to see in the district, or that is desperately needed in order for us to make a dent in the level of deaths that we're seeing here in DC?
Thank you for asking that question. There are at least 4 people on the Opioid Abatement Commission that initiated their work in this space in my office. Dr. Settles Reeves was part of the team that Dr. William Lawson and I put together back in 2013 at Howard University called the Urban Health Initiative. And that's where we developed the platform for telehealth. Mr. Bing, of course, is a patient, and Jeffrey Chad Jackson was one of the students in the master's program that I participate in at Georgetown University for the past 6 years. So, Larry Gordine also started in my office. So collaboration is the key. And unfortunately, if we don't have the leadership from the government, we will continue to have a fragmented approach to treatment where people operate in silos. We have to define what our limitations are. The whole idea of the Urban Health Initiative was the fact that I'm an internist with a subspecialty in addiction medicine, but I'm not a psychiatrist. So we set that platform up with the realization that there is a shortage of mental health workers. And by having a remote office, that my patients frequently have economic problems, travel problems, when they come in for their medication renewal, that we could connect them through telehealth to either a psychiatrist if they needed housing, to a social worker without moving that patient. That was the original design. So moving forward, if we were able to use the various skills that we have and share those resources, and I think what I've advocated in my talks across the country is a bundled payment system, very much like the district's ACT program, assertive community treatment program that gives a bundled payment that would cover all of those additional services. I have a number of patients who are homeless, which means that under that payment design, that we could afford to make those payments and get patients where they need to be. I don't think that, unfortunately, that carving these patients into the managed care organizations is going to be a solution. And the reason why is I battled for years over dosing with the medical directors of some of the past and present providers of service who often cap dosing for buprenorphine at 24 milligrams. Again, I'm going to reiterate, we knew 8 years ago, 8 years ago, that we were faced with an unusual circumstance that our patient population needed higher doses than were recommended by the FDA. We've written the FDA, I've sent a number of emails, and now those studies are confirming everything that we said. Some states have already raised the dosing rate to 32 milligrams. And if you look very closely at the intramuscular or sub-Q form of buprenorphine, if you look at those studies very closely, you will see that when the FDA approved those medications, they actually did allow higher doses in that patients were routinely supposed to be dosed every 28 days, but in some instances they allowed 21 days. So they actually boosted the dose, recognizing that our patients metabolize these drugs much differently.
Thank you for that. I really appreciate it. Dr. Settle-Reeves, are you there?
Yes, can you hear me?
If you are, I would ask a similar question, given your participation on the commission as well. How do we perfect the coordination that the city so desperately needs?
First of all, thank you for the opportunity to be here and testify, and I'm honored to be on the abatement committee as well. This has been an issue I've been trying to deal with for a very long time in terms of providing the wraparound services. I am with the Howard University Urban Health Initiative, and we are functioning on low staff, as Dr. Henderson addressed to some of our other participants. Their staff, we're losing people. So one of the problems, and funding. The second part is in terms of connections. I've been dealing with this for a long time. And let me tell you something. This city is highly congested with plenty of expertise, agencies, services to help the community we're discussing. We need to have a better network. And I can say, for example, I should be able to reach out to any of those agencies in the city to get to a patient, to refer a patient, to assist a patient. We have to eliminate, first of all, some of the competition among us, because that does put up barriers. And by making this a crisis, everybody drops the barriers, and this is only about the focus and the emergency that is at hand. And we need to do that. We need to have a database that we should be able to instantly click on and reach someone at an agency where a patient may be 2 minutes away from. We need to do that, because our patients will contact the agencies that they're working with or the organizations they're working with first, and they may be in the midst of a storm and can't get all the way across town to us. But I should be able to click on someone and say, hey, I have a patient here. Can you see them? We need to be networking at that level. in order to deal with this. And yes, it is a crisis. It's not declared, but it's already at a crisis point, and it's beyond the crisis point. We're swimming in it. And all of these agencies were working and dedicated, and our peers who we need to put at the top of the list because they are in the community, they are there, they should be able to make a connection instantly, 24 hours, because they are working 24 hours out there.
Thank you for
And
that.
they're seeing what's happening. And they have the language. They reach the people. They talk to them. Yes, we need to be in the schools. We're starting to see patients younger in their 20s. And we're not necessarily catching them through psychiatry or on the or PIW. We're not necessarily catching them through the behavioral health system.
Yes.
We've been catching a lot of these patients now through our medical units.
That
And we
is
have-
that is my time, unfortunately. I agree with
sorry.
everything
Thank
you're
you.
saying.
Thank you.
Councilmember Henderson, is it possible to get an extra 60 seconds? I see Michael has his hand up.
Thank you.
Okay, go for it, Michael. And I just want to say I really appreciate everything that RAP has done and continues to do. And I know you all are facing some issues with DC government that we're working on, but even that speaks to the ways in which we need to make it easier for people like you and those at RAP who are trying to make a difference in our community. But 60 seconds to jump in here.
I won't take 60 seconds. All I'm going to say is we need to, and by we, it's I mean DBH and DHCF. We need to have a bed board that includes residential and outpatient, and we need to we need to do that. We need to know where resources are so that all providers can say, you know, whether you're in, you know, ward 5 through 8, this is what's available to you, and we've talked about it for a lot of years, but we haven't been able to pull it off.
No, thank you for that. That is my time. I will follow up with you on that, and I will be sure to ask Dr. Bazaran about what progress has been made or her vision for moving in that direction. But thank you all for your testimony.
Thank you, Councilmember Parker, and thank you to this panel of witnesses. Mr. Pickering, I would just say, I think the question about a dashboard came up at our last hearing around opioids, because I had a similar question of if we had someone who came to us or we had a provider who was looking for a space or a slot for treatment, we don't have the same type of visibility into, say, this visibility that we have into who is in an emergency room and who has a bed or not, even down to, you know, who has you know, labor and delivery bed or not. We have dashboards that provide visibility into some of those things, but not into this. So we'll definitely follow up on that. But thank you again to all of these public witnesses. Okay, so we have been going for about 2 hours now. We're gonna take a 5-minute break, and then when we come back, we're gonna hear from our government witnesses. For those who, please make sure you provide your testimony, your written testimony, if you haven't done so already. So 5 minutes, and then we'll hear from Dr. Bazaran, who will be presenting testimony on behalf of the government, and then we'll ask some questions from there. All right, thank you.
That's all I need. Okay.
All right. We will now call the government witnesses, Dr. Barbara Bazaron, who's the director of the Department of Behavioral Health, Dr. Ayanna Bennett, who is the acting director of DC Health, and Dr. Robert Holman, who is the medical director for the district Fire and Emergency Medical Services Agency. Before we begin, I will ask that everyone, you and anyone on your team who might answer questions, we need to swear you in. So if you can raise your right hand. What's that? Oh, they're in the bathroom. Okay. I'll give it like a, we're going to extend grace on that front. Okay. Do you swear or affirm under the penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. I believe Dr. Bazaron, you're presenting the testimony, and other two of you will be available for questions. Great. Dr. Bazaron, you want to turn your mic on and present?
Is my mic on? Okay, thank you, and good morning, Chairperson Henderson, council members, and council staff. I'm Dr. Barbara J. Bazaron, Director of the Department of Behavioral Health. Under the leadership of Mayor Bowser and the guidance of Deputy Mayor Wayne Turnage, DBH supports healthier and stronger communities by working to prevent the onset of mental and substance use disorders and providing a range of treatment services and recovery supports. The sense of the Council on the Opioid and Fentanyl Epidemic Resolution of 2023, PR25-0386, presents an opportunity to update the committee and the public on the work taking place through Live Long DC, the district's plan to implement prevention, harm reduction, treatment, and recovery strategies to save and change lives. We submitted detailed responses to the committee's pre-hearing questions, so I will give a broad overview of our work and take a moment to talk about how we go here. Mayor Bowser has provided nimble strategic direction and used available tools to mobilize the DC government to fight the opioid epidemic with urgency, strong interagency coordination, and strategies tailored to DC. From the beginning, the district has taken a public health approach to combating the opioid epidemic, which stigmatizes addiction, recognizes that we must address the social determinants that affect drug use, and advance health equity. Years before the Live Long DC plan was released in December of 2018, Mayor Bowser had focused her administration on gathering and sharing data to better understand opioid use in DC and to put in place strategies to help residents addicted to opioids. For example, between May and August of 2015, the DC Department of Fire and Emergency Medical Services and DBH implemented ESPERT, the Screening Brief Intervention and Referral to Treatment pilot initiative to offer immediate access to treatment to individuals who experience an opioid overdose. Through the initiative, the district gathered critical information about DC's opioid epidemic and the demographics of those affected. These data were used to inform our strategy. While fire and emergency medical services already carried naloxone to reverse a suspected opioid overdose, a community naloxone pilot program was set up to train and certify staff and community members affiliated with the district's needle exchange program to administer naloxone. In addition, the DC Office of the Chief Medical Examiner and the Department of Forensic Services collaborated to improve toxicology testing and reporting to better track specific drugs to inform our intervention strategies to reduce the risk of individuals and communities. These reports identified that synthetic fentanyl replaced heroin in 2017 as the prevalent drug in overdose deaths and alerted us to the emerging trends of the misuse and mixed use of xylazine. On October 12th of 2016, Mayor Bowser and the governors of Maryland and Virginia signed the National Capital Regional Compact to combat opioid addiction to increase collaboration to fight opioid addiction in our region. The following year, on May 9th, Mayor Bowser hosted a regional summit attended by hundreds of policymakers and public health and safety professionals from across the region to discuss the many challenges associated with the growing epidemic. This early work kicked off a year of planning and collaboration with more than 40 community-based groups, along with government agencies and federal partners that resulted in the release of Live Long DC, the strategic plan in December of 2018. Today, the movement to fight the opioid epidemic is rooted in work taking place in communities by leaders and organizations who work, many for decades, to keep their neighborhoods safe, healthy, and strong. Through this work, Live Long DC is changing the landscape with rapid access to treatment through multiple avenues, including hospital emergency departments, public schools, health clinics, primary clinics, and the DC jail. Expanded access to medication-assisted treatment, development of an ecosystem of harm reduction that is preventing opioid-related deaths and mobilizing the community to fight the opioid epidemic. A culture of awareness in substance use disorders that is a chronic relapsing disease to reduce stigma around addiction with growing leadership from the faith-based community. New recovery supports, peers throughout the system of care, and a robust overdose surveillance that allows a rapid response and individual engagement and access points throughout the criminal justice system. Keep in mind that this work took place during 3 years of the COVID public health emergency, which increased isolation, disrupted treatment regimens, and limited engagement opportunities. We are still refining our understanding and addressing the impact of the public health emergency on the behavioral health of our community. Our movement integrates peer leadership and support throughout our strategies. DBH funded 4 peer-operated centers where peers model resilience and recovery, connect people to treatment, and provide recovery supports and services. Primary care settings provide an opportunity to address opioid use disorders. Through our work with the DC Hospital Association, every person who comes to an emergency room department of any community hospital is screened for substance use disorders. More than 882,730 screenings have taken place in hospital emergency departments since 2019. Hundreds of overdose survivors started medication-assisted treatment right there with peers located in a hospital to engage them to stay in treatment. We also have partnered with the Psychiatric Institute of Washington and 5 federally qualified health centers. Opioid overdose deaths are preventable. Harm reduction is the heart of our fight to save lives. Harm reduction is an evidence-based approach to work with people who are using drugs to keep them alive and as healthy as possible while engaging them to seek treatment. Harm reduction also engages families and friends and brings in the community to be a part of our overdose prevention strategy. Our harm reduction strategy includes widespread availability of life-saving naloxone and fentanyl test strips and a safe syringe program with mobile units to respond throughout DC. Nearly 5,700 suspected overdose reversals using naloxone have been reported by our community partners, which includes MPD, fire and emergency medical services, and others. The district is a national leader, making life-saving naloxone free and easy to get. More than 276,000 naloxone kits have been distributed through 130 sites across the district, in person, by mail, or by delivery. Currently, there is a vending machine with free naloxone and other health hygiene supplies located in 3 fire stations throughout the district. Our commitment to harm reduction to prevent overdose deaths is matched by our commitment to expand ways for people to get into treatment and sustain recovery. Working with our partners, we have made it easier to access treatment through multiple entry points and 24-hour access to treatment. In fiscal year 23, compared to the same time last year, there was a 16% increase in the number of people in medication-assisted treatment, driven by an increase in buprenorphine treatment by primary care physicians. About 2,000 DC residents are managing their opioid use disorders with medication and counseling. To avoid disruption in care for people who might become involved with the criminal justice system, treatment units for men and women are located in the DC jail to maintain medication assisted treatment and counseling. We offer free transportation to DBH certified providers located in all 8 wards, medication assisted treatment centers, and a roving DBH mobile van. Crisis counselors and crisis beds are available day and night. In the new DC Stabilization and Sobering Center scheduled to open in the coming days will offer a safe place for individuals under the influence of drugs or alcohol to stabilize and get connected to care and other supports. We are also offering a path to treatment for special populations through our work to train staff in skilled nursing and long-term care facilities, and our guide to aid the screening and treatment of pregnant and parent and postpartum women. Safe supported housing is crucial for individuals to sustain recovery. Along with Oxford House, DBH has added a new model of recovery housing that provides intensive care management and counseling for individuals who may relapse in their recovery from this chronic disease. We also set aside recovery housing for men and women returning from incarceration. Currently, 500 individuals, including returning citizens, live in recovery housing. With our partners, we have established a robust collection of systems that inform our strategies, including when and where to deploy outreach teams. Through the work of community-based organizations, the work-based prevention centers, and faith leaders, we have focused attention on prevention of opioid use and combating the damaging stereotype that addiction is a personal weakness or a cause of shame. Thousands of residents have participated in hundreds of community meetings and other activities that promote an understanding of addiction as a disease. Thousands have naloxone on hand and are ready to save a life of a loved one at risk of an overdose, a neighbor, or even a stranger. Our robust social media and marketing campaigns have broken down stereotypes with personal stories of recovery. In looking ahead, we're closely examining the data and reviewing our activities to identify what's working well and to address new and emerging issues. We're working with partners to update Live Long DC and anticipate the revised plan, which we hope to release soon, will add support for young people, increase funding for faith-based groups, award many grants to community-based efforts, target recovery housing for those with medical needs and pregnant women and women with children. Councilmember Henderson, you attended the first meeting of the new Opioid Abatement Advisory Commission yesterday that puts us on the path to awarding grants from the Opioid Abatement Fund to complement the work of Live Long DC. During our presentation on the gaps and needs assessment based upon our current work, we presented the following challenges to address opioid use disorders. 61% of people receiving substance use disorder treatment in FY22 were treated for co-occurring mental illness. A significant number of people have complex physical health issues. Maintaining treatment and recovery for a chronic relapsing illness continues to be a challenge. And 66% of the people who died from an opioid overdose last year were in their own homes or the homes of family and friends. And 17% of people who died either lived in Maryland or Virginia, or their residence was unknown. We have ideas about how we can address these challenges, such as expanding the work that fire and emergency medical services is doing to follow up with non-fatal overdose survivors and focusing on occupations at high risk of opioid use and related death, including construction and nightlife workers, which might help us to reach the non-DC residents. We look forward to a conversation about the use of the Opioid Abatement Fund to support high impact strategies that strengthen our work. This concludes my remark, and I and my colleagues will look forward to this discussion. Thank you.
Thank you. Councilmember Parker will be on 10-minute rounds. Okay, great. Thank you, Dr. Bowser, on for that testimony that was comprehensive in nature and yet didn't necessarily answer the central question of whether or not the Bowser administration views the opioid crisis in the city right now as a public health emergency.
I'm sorry. The administration is certainly willing to have the discussion, particularly with respect to the declaration.
Okay. I was looking at the latest report that we received from FEMS, Dr. Holman, that looked at October 1 of 2022 to I think October 19th of 2023. And also realizing too, it went a little further, but then also I think there might have been a week that's sort of cut off in the data. And, we could talk about fatal overdoses, but 5,261 suspected overdoses overall. When we think about the number of people in our city, that's a lot of time that your staff, that EMTs, that MPD, that hospitals are seeing. Is this a crisis for FEMS?
So we are a very busy department. One of the busiest, Washington, D.C. has one of the highest 911 call ratios per capita in the country. We used to be number one. I think we're now down to number 5. We're very busy. Opioid overdose and suspected opioid overdose is something that everyone sees day in and day out.
Yeah.
So I'm not sure how you would define the crisis, but it is certainly for the last several years been something that we've been facing day in and day out.
Yeah, I noticed that from one of the earlier reports from suspected overdose cases, you all went 0 days where you didn't receive a call about a suspected overdose case. So in my view, that says crisis. We got to do something because, Dr. Bowser and I appreciate that you all are doing Live Long DC 3.0. But when we first launched Live Long DC in 2018, it was with the goal of cutting the numbers, of cutting opioid misuse and related deaths by 2020. And we doubled. Now, I recognize that the drug supply changed, but now I guess then the question is, how are our strategies changing to address our new reality? Because in, I think 2014, we were dealing with 84 opioid related overdoses. And now we're cresting 461. That was last year. I'm sure we'll hit over 500 this year. So something changed, but then our strategy didn't.
I think here again, as we have looked at the data and considered what other sorts of things we might do, I think targeting, for example, those individuals with non-fatal overdoses is one strategy that we can certainly use. And then making sure that there's a good follow-up and care coordination to engage and keep those individuals in care. The other thing I think is to look at where fatal overdoses are happening. And in my remarks, I did talk about the fact that a lot of this is happening inside people's homes.
Right.
And so here again, we really need to make sure that the public is educated and that, they know not only about the impact of the drugs, what the drugs are actually, because they're changing on a daily basis, as you heard during testimony today, and that we can address them. I think also one of the things is looking at some of the high impact groups like construction workers. I know I've looked at data, for example, in Australia, where one of their strategies was to really address construction workers and
just to sort of interrupt Dr. Bowser. And so on the construction worker front, yes, I can understand perhaps
Mhm.
in those hard, it's pain management, but our situation is not prescriptions. Our situations is fentanyl, which is different.
Well,
And I know that most, if not all of our construction companies in DC, and I've talked to the unions, they drug test on a regular basis.
Mhm.
So I don't know if that's, while Australia, that might be their situation. I don't necessarily think that's here in DC.
Well, what we have seen is that if you look at the data and you look at the high occupations that are happening here in the district, the construction industry is a part of that. Now, I don't deny that they are doing drug testing. I don't deny that they have other methods in place, but here again, construction and nightlife are two of those high occupations.
Okay. So on the data front, one of the things that FEMS shared was you
And
do,
also, I'm sorry if I
Okay.
might,
go ahead.
also the whole, a couple of things that came up, and that's intensive care coordination is one of the things that we have put in place to change and improve our strategy. We want to do more of that. And we also want to do more in terms of expanding the efforts that Fire and Emergency Management Services is doing right now, where we are meeting people right at the point at the hospital and with peers, and then beginning to not only work with individuals
Mhm.
around getting them into care, but identifying and then doing the follow-up services and supports.
So let's talk a little bit about the data. One of the things that FEMS one of the things that FEMS reports on, and I can't necessarily take it as 100% accurate because sometimes people refuse your questions, is whether or not the patient reported having a previous overdose.
Mhm.
And in the last quarter, or so that's July 9th to July 9th, or so July 9th to October 19th, approximately 19% said yes, they had had an overdose
Mhm.
before. Dr. Bazaran, you talked about how do we follow up with the individuals for non-fatal overdoses? And I think in some ways is we have to sort of slice this up. There are some people who transport to the hospitals, and that's great. They could talk to the peer, specialists who are
Some
there
don't.
in the emergency rooms.
Mhm.
Then there are the individuals who refuse transport.
Mhm.
What do we do about those individuals? And Dr. Holman, or I think Dr. Bazaran mentioned
Mhm.
that FEMS is doing something along this lines. Can you expound upon that?
Yes, we are working together in collaboration, and Dr. Holman can speak to that.
So we have a street calls unit that we've had for many years, and we've, in collaboration with DBH, we have hired community outreach specialists to be part of that team. So we have 4 teams now where we have an EMT or a paramedic paired with a community outreach specialist. And those teams are alerted whenever our crews in the field encounter an individual with suspected opiate overdose or real, that they reverse with Narcan, but then that individual refuses transport, then we alert the street calls team to come to the site right then. They get there in approximately 20 minutes or so, and they try and engage the individual right after the overdose and engage that person or the bystanders with education about the ubiquity of fentanyl and the danger thereof. Provide Narcan, provide fentanyl test strips, and engage the surrounding bystanders.
How often are they seeing penetration in their efforts?
I think it's a little too early to say whether.
When did this start?
We started a few months ago.
Oh, okay.
Yeah.
I heard a few years. It's
No, the street calls has expanded its mission just
Okay.
a few months ago.
okay.
So-
So what month? What's the definition of few?
Ooh, I would say maybe July. Yeah.
July. Okay. Okay.
So we will have data for you in the near future, I hope.
Okay. And so 4 teams. So approximately how many people?
There's 8
8.
is the full component. We haven't staffed up to a full 8 yet.
Okay. So is it 8 every shift or 8
No,
in a
it's,
day?
so it is currently 4 teams of 2 working regular business hours. And in the next several weeks, we will be expanding to evening and weekends.
Okay. So
to really
we're
meet where the patients
so
are.
currently right now, these teams are only available 8:30 to 5:30.
Yeah.
Okay.
business hours. Yes.
Okay. I don't have enough time. Councilmember Parker.
Thank you. I just want to be clear. So do we have a crisis in DC with opioids? Dr. Bazran?
What I can say.
And I'm
is-
asking you as Dr. Bazran, not to speak on behalf of the mayor.
What I can say is that, what we see is that people are dying. And we do see, if we compare the data over years, that as a result of fentanyl and xylazine and other things that are coming into the drug supply, there is a greater impact on our
And-
community.
The level of people dying in the city, has that reached a crisis level?
I think one death is too many from my
Yes.
perspective,
So what
one
I'm
death
hearing you
is a
say is,
death
yes,
too
we
many.
do have a public health crisis involving opioids in the District of Columbia.
As I said, I think one death is a death too many,
Okay.
and so we need to address it.
Can you speak to what coordination exists across the executive with DBH? I know there is a lot of coordination, but
Yes.
specifically targeting the number of deaths that we're seeing on the streets,
Mhm.
what does that weekly, daily coordination look like?
Well, first of all, I think through Live Long DC, we actually do, we have, cross-agency groups that involve a wide range of government agencies, DC Health, FEMS, the MPD. I can go down the whole list of human services and other.
And how often are
agencies.
you all connecting to
They,
talk about strategies to disrupt the number of deaths?
well, I know that formally, we have a formal meeting once a month to kind of look at the data and to talk about what we need to do differently. But in between there are lots of meetings,
Yes.
lots of committee meetings and focused meetings on particular strategies that include not only the government, but it's informed by the community.
Okay. It goes without saying that I think we need to do more. And I'm speaking with respect because I know you're working in a broader executive team and you may not necessarily be able to call all the shots. I do recognize that. I just hope that as a city, we can address the carnage that is playing out, namely in wards 5, 7, and 8. And so when there seems to be hesitancy in naming the crisis that is so evident, that is impacting predominantly the Blackest wards in the city, it begs the question, why? That's one. Two, we know there is also a broader public safety crisis. And it's not lost on me that these things go hand in hand. I know we've had discussions about that. Can you speak to, and if this is too premature, I will respect that. But I know the mayor has announced new criminal legislation or legislation to address drug-free zones. What work is DBH doing with the mayor's team with respect to that legislation? Or how are you informing through this critical lens of the opioid crisis that's facing the district to say, these are the strategies we should be leveraging to address these drug-free zones?
Oh, I'm on. One of the things, I guess, as you know, the legislation and that activity just took place literally a few days ago. We work very closely with MPD in terms of sharing information, generating ideas and developing strategies, and we will continue to do that. We do that in an ongoing basis and have
Okay.
been doing that for several years.
I have not seen the legislation. Councilmember Henderson, have you seen the legislation?
Not the
I mean, the
draft. I've seen a draft.
with
Okay.
the-
So
the bill
I
or
too look
whatever.
forward to seeing it. I will say what my hope is, because as Dr. Chapman alluded to in his comments earlier, this is a health crisis. And so connecting those two, yes, we need to hold people accountable that cause harm and break the law. But also, I hope DBH will be there to stand in the gap in these drug-free zones in the aftermath to provide care and the coordination that we are all talking about. And I trust that you will. If that is not the conversation that is happening, I hope that the executive can lean in that direction. Again, I haven't seen it, so maybe that's part of the broader vision. I don't know. It seemed like you were going to say something. I'm talking about the mayor's latest public safety legislation that she had a press conference about earlier this week.
Well, what I'm saying is that the Department of Behavioral Health has worked very, very closely and continuously with MPD.
Yes.
And one of the things that we've been clear about is the intersection and the relationship between our two agencies. Like, for example, if we're doing a co-response model, we are very clear that somebody who may encounter MPD may also have a behavioral health care concern, and we need to be there to address that issue.
I'll be more pointed and I make it, I have no doubt that Dr. Bazaran is thinking about these things. I've seen you demonstrate that level of commitment and coordination this week. I'll keep saying that.
Yeah.
I'm not persuaded that whoever is leading a broader sense of coordination across the executive team is thinking about that. And so what I'm offering is, it is my hope, whether it's with the legislation that will come before the council soon, whether it's around coordination and the work of the opioid abatement council, or whether it's those coordination meetings you're saying are going on, that there is just a greater upward management, let's say, to make sure that that is a priority, because it seems like these things are operating in silos. Let me go to my other question. I did want to come to the Opioid Abatement Commission. Really excited that that has finally been seated. But even that is an example of, it shouldn't have taken as long as it did, quite frankly. And again, that's not a Dr. Bazaran decision. That's what I mean by upward management, All right, let me get to my question. Can you just confirm the amount of money that the commission has access to at this moment?
It's almost 14 million. It was like 13.9 million. And that's just with the Opioid Abatement Commission.
Okay. And does and I know you are part of that commission, as is Councilmember Henderson, and Dr. Bennett, is DBH planning to provide recommendations for how that money should be spent?
Well, I think here again, as I've said in my testimony today, and as we said yesterday, we do have information based upon the needs assessment data that we've done through Live Long DC that can at least provide a starting point for looking at that. However, we do anticipate that the commissioners will have ideas, suggestions based upon their knowledge that they bring to the table regarding what we might do. And the commission will then make those recommendations.
Yes, I'll use my last minute to say, so again, the coordination that I trust is happening. The meetings that I know you're sitting in, I would hope that would color a vision for the executive and DBH, that there could also be and I hear what you're saying, the commissioners will make the decision around how the money is spent. But those commissioners don't have the level of access that you via DBH, they don't have that level of access. And so I guess I just am concerned that we have a great opportunity to really advance real solutions in the district. And that should be coordinated with all of the other work through district government.
Correct.
It should be connected to the legislation that's being rolled out by the executive. And I don't mean to come off as though I'm preaching to you or being condescending. And if I am coming off that way, I apologize. But it is a little frustrating that this is now what, the fourth or fifth hearing we've had on opioids. And we can't even just clearly say we have a crisis that is primarily impacting communities like mine.
Well,
I will give you the last 10 seconds. I am over time.
okay, if I might say,
Yes.
I think the Live Long DC provides a framework within which the Opioid Abatement Commission and all of us within the district can work to advance forward in terms of addressing the crisis.
Thank you.
Dr. Basran, let's talk a little bit in terms of the Live Long DC. Is there a scorecard? How do we track the success of Live Long DC?
We do have measures that we track, and also we do an evaluation. And I do believe that we shared some of that information in our folder. And if not, I'll make sure that you can get information.
Okay, I'm trying to sort of temper here because there was a long stretch of time where I feel like it was quiet. And then we announced this hearing and then a lot of things started happening. We find out that Live Long DC is about to be updated. The Opioid Commission is having their first meeting. The Stabilization Center now has an opening date. And so I'm trying to understand, if I go to, and we've talked about this, when I go to the Live Long DC website, it hadn't been updated in months. And now it is with, things in the last 2 weeks. And so we keep talking about Live Long DC as our framework, and yet I don't see us actively going to the framework to determine whether or not it's working. So let me ask this. Dr. Bennett, in your confirmation hearing, you talked about data and metrics and how you feel like that is very important to drive the work. I know that FEMS provides data and information because they're getting it from the hospitals, they're getting it from others. What type of data does DC Health have in pertaining to opioids?
So that is one of the central roles that DC Health is playing as chief strategist. It is to give the data and a sense of where this problem is happening and to who. So we actually receive the information from the hospitals. We share that and coordinate with the information that's coming from FEMS, but that the ability to try to geomap where these things are happening, the work of the medical examiner's office is coordinated with our own work so that that data is analyzed in conjunction with all of the other sources. So that is the data that DC Health gives you. Some of what you've been quoting comes out of DC Health.
Okay, so OCME posts their data monthly. For FEMS data, we have to request it. From DC Health data, I don't know where, is it posted anywhere? Who has access to the data? Who has access to your data, Dr. Holman?
So we share our data with DC Health continuously, daily. And we have public facing data that may not answer the question you're looking for if you're not seeing it.
Okay. Like what type of public facing data do you all have?
We have all about our runs, what kind of runs we run,
Okay,
et cetera. We don't have granular data about geomapping our Narcan reversals.
Okay,
That's
okay.
the sort of stuff that we share with our agencies of interest, DBH and DOH.
okay.
So
once we have the data, what happens? Do you share this data with, say, MPD?
We do make the data available. I don't know if there's a unfortunately regular meeting with them to give them on the ground data at the moment.
Okay.
Just the
I think
data
in
so
the
you
binder of
that.
information we got yesterday from the commission, there might have mentioned something about there being an opioid working group.
There is.
Who sits on that?
There is a data work group, and that is a part of Live Long DC, and there are agency representatives as
Which
well
agencies?
as other members. I think it's all of the agencies, as I recall. And so DC Health sits
hold
on
on.
it. Let me just tell you,
Okay.
DC Health
Okay.
sits on it. MPD. I'm trying to go through all the human services agencies that are members of of
So
Long
I could
DC.
suspect maybe most of the agencies in the health cluster, minus probably health
Mhm.
benefit exchange.
Mhm. As
Mo-
well as the CME.
So most of the agencies in the public safety and justice cluster is
Mhm.
GYRS part of it?
I'm not sure whether DYRS is a part of it.
Is they've got some opioid stuff going
Yeah,
down
but I'm
at
not sure. as
their
I'm
facilities
saying,
too.
yeah.
Okay. How often does
think
the
so.
opioid working group meet?
Is that monthly? It's monthly.
Okay. And what activities have come out of said working group meetings?
Well, I think that here again, in terms of determining what's going to happen in Live Long DC, what kinds of things we need to do better or differently. For example, one of the things we looked at were the need for housing and recovery housing in particular. And so as a result of the fact that we knew that people were who had substance use disorders, who were moving into recovery, did not have adequate housing, we began to open up more housing, and particularly low barrier housing.
Shelters?
No, low barrier recovery housing. So that's environmental stability,
Okay.
which is housing that someone can step into for 6 months as they are stepping out of care, out of residential care. And also, we have also created some low barrier housing.
Okay, how
'Cause
many
even though
beds?
we have 13 beds.
Mhm.
And that's in addition to the Oxford houses that we have.
And how many beds are available
And
there?
How many Oxford houses? About 500, yeah.
Okay. Are there minutes from the working group meetings?
Yes,
You take attendance?
yes, there are minutes, and there are minutes with attendance, there are minutes.
Okay. How long have we had a working group?
I know at least since I've been here, and so that's been 4 years, and probably before then. But I can account for that amount of time.
Okay. And what would you say in the 4 years has been a successful achievement outcome to move the needle from said working group meeting?
Well, here again, as I said, I think that we have identified things like we needed to move to harm reduction. If you remember, that was not necessarily. our
Okay. So the
strategy.
decision around Narcan, fentanyl strips, et cetera, sort of came out of that group.
That's correct.
Okay. So here's the thing that I feel like is one of the tension points of what I'm trying to raise here is that the public and other members of the government, I'm including myself on this because I chair this committee and I saw a working group, but I didn't even know that it existed. I didn't know who the members were. I didn't know how often it was.
Mhm.
I see a crisis in terms of the numbers. I see a crisis in terms of the bodies. I see a crisis in terms of the parents who are calling our office trying to find help and care for what they're experiencing with their young people.
Mhm.
And yet we say everybody's collaborating, but Dr. Brennan, you said, and I remember this, collaboration is a physical activity. And yet I see no outcomes from said collaboration that is happening amongst our government when it comes to this particular issue.
Mhm.
And I'm not doubting that Live Long DC is a great framework, but the reason I'm setting it aside is because it hasn't been working. Our numbers are going up. I don't know if we can even point to a single subgroup to say, okay, we've got it together with our young people. Okay, we're seeing a number go down with seniors. Okay, we're seeing a number go down with unhoused folks, or we've adjusted the numbers in some of the things. Like, I think we need to see what are the actual, say it out loud. These are the strategies that we are working on. This is the metrics that we're going to use to say, this is working, it's not working. We're going to try this for 6 months. I'm really interested, Dr. Holman, to see what the data outcome is going to be from, okay, you don't want to transport, fine. We're going to allow for our EMTs to get to their next call, but we're going to have another group come right in to follow up so that you're just not another call. Because I think that could help. I know we see a little bit of that data information that happens in the sort of the hospital pieces, but again, these are with individuals who've taken up transport, not the other pieces that are kind of sort of happening here. Let me ask this. Is there data that our agencies can make available on the Live Long DC website? In the same manner that OCME every month provides surveillance reports about what's happening? Because he only covers fatal. He doesn't give me information about non-fatal.
Mhm.
Like, who's the
Mhm.
decider in terms of whether data can be made available?
The
Oh,
data
yes.
exists, so it can
Yes.
be given.
Yes, the
and
data
posted.
exists, so it can be
Yes.
posted.
So the non-fatal overdoses is also a
Oh,
piece of
yes.
data that we do
collect that.
follow. DC
Mhm.
Health is responsible for doing that, and we do.
Okay. What's that? Okay, which agency manages my recovery?
We do.
DC?
My Recovery DC?
Yes,
The stories? Yes.
the stories. What do you mean?
My Recovery DC, that particular website is managed by the Department of Behavioral Health. And it does provide individuals who have experienced opioid issues and their recovery stories.
Okay. I'm over my time. I'm gonna come back to this, or my next round of questions is gonna be about the public outreach and promotion piece. Councilmember Parker.
So I want to pick up on the data. So can you give a range of time when we can expect to receive the non-fatal data points?
They can come to you anytime. So I will go back after this and get those to you as soon as possible.
Mhm.
The posting is just,
Yeah.
we can deliver to
Right.
DBH, who runs the website, to have them posted.
Okay. And is that data broken down by demographics and or regions of the city?
All the data is and can be. When the numbers there are
Mhm.
statistical issues sometimes around whether or not you can trust that report.
Okay.
When you're trying to extrapolate from it, because it's not everyone, right? We don't get information about reversals that happen in people's houses, and there are lots of events that don't get included in that database. So it gives us a picture, but not a full and complete one.
Okay. I do, before I switch gears, there's also a tension between work happening downtown and work happening in communities. For any of you, how do you operate, or how can we operate more in the community to provide these supports, employ these strategies to meet people where they are? And what I mean by that, like, yeah, we can say we're meeting, we're coordinating, we have this framework, but when are we actually getting out in Ivy City or Trinidad or any other area in the city that is plagued with these issues? Do you have an idea of how we can better do that?
DC Health's role is in many ways supportive, but we also have overdose related services for the populations that we are very closely involved in. So we do have vending machines for our populations that are being served in various services. The groups that are on the ground, we have peer groups that go out and hand out Narcan and do other things. Many of those things are sized according to the funding that is attached to them. So they exist and they are directed where it seems the most effective. And they are things that could be expanded if there was more funding.
Okay.
Which we now have in abatement.
Sure.
Councilmember Parker, I wanted to just add a comment to that. We have hands-only CPR training, which we call Hands on Hearts. And for the last year, we have included Narcan distribution as part of that, and education about how to use the Narcan, not just handing out the kits. We have these hands-on hearts training in communities throughout the cities, usually at community events, parades, and the like. But we've actually looked at neighborhoods that have a higher incidence of cardiac arrest, but a low incidence of bystander CPR, which does identify a gap there. And so we've actually targeted those neighborhoods for hands-on heart training. And so to answer your point, how are we targeting those communities? Those are underserved communities in general. And so we've tried to push this out as well.
No, and thank you for that. And you all participated in Ward 5 Day, and it was a great success. I will invite, and I see you, Dr. Bassaran. I want to get to you. I will invite all of you all to partner with us in Ward 5 and 2 communities that we're working really closely in, the broader Bloomingdale area along North Capitol that is facing many challenges here, as well as the broader Trinidad community. Fortunately, in this year's budget, we were able to secure some resources for on-the-ground support. And I just want to keep pushing us to just think about how do we get out of this building and our respective silos and into the communities where the people are actually dying and have issues. Dr. Bassaran.
Yes, I wanted to address that. We, as a result of the feedback and the analysis through Live Long DC, we did have started, and now I think it's been almost 2 years, ward level meetings where we meet with people in wards to really look at what strategies would work, what some of the issues are, and so forth. And there are data reports related. That ward level data is available on our website, along with, we do have non-fatal overdose data also on the
So
website.
am I hearing you say that members of that team will come out, coordinate with communities
Correct.
and
Yeah.
come up with
Plans.
specific strategies,
Correct.
and DBH will help execute that on the ground?
That's correct.
Oh, great.
And
I'm
Dr.
gonna set-
Sharon
we're
Hunt,
gonna set something
actually,
up
who
for
is
Ward
sitting
5.
here, has been leading that effort.
Okay, I'm gonna follow up with you all on that. Thank you. There was a mention about peer supports. Dr. Bennett, you talked about that, but I actually want to come to Dr. Bassaran. The last time we talked, we discussed the certification. And currently here in DC, we don't have a nationally recognized certification. What is the update there? Because you
Well,
said that
first
was
of all,
one of the goals.
thank you for that question.
Yes.
We have restarted our certification process so that people can go through the DBH certification process, and we are still working with the national organization. A part of one of the issues is the huge number of hours that they require for internships and a couple of the other things. And so we're still trying to work through that, but we didn't want to wait. So we have gone ahead and reinstituted our training so that our peers can get at least certified here within the district.
Okay, can you give us a window of time? Is that, do we expect by this time next year we'll have it?
We are having ongoing discussions with the national group and trying to work it through as quickly as possible. I would have liked to have happened months ago, but it's really been a pretty laborious process. So I
Okay.
can keep you up to date in terms of, how we are faring.
Please do, because I think that is a key lever for us here in the district.
Mhm.
And we need to prioritize and,
Sure.
act with urgency there. Dr. Ben, I want to come to ask for the timeline to create a recognized certification completion process for community health workers for use in the substance use disorder and the opioid use disorder categories.
You're asking for a specific, so let me ask.
Okay, no worries. And while we get clarification there, I'm jumping around because some of these questions have already been asked. Dr. Bassaran, is there any plan to have a sobering center located in wards 5, 7, or 8?
I'd like to have them in every ward. Right now, we do have another one coming on board. And I'm certainly open to
As in,
that.
that's the second one?
Yeah, yeah.
Who makes that decision? Like, is that you, or is that again someone above you?
The mayor really will make that decision.
Okay. I just will underscore again, we have a crisis, and that crisis is pretty clearly impacting certain parts of the city. And I'm not saying Columbia Heights and other areas don't deserve support because they definitely do. But it again begs the question, why? And what are we prioritizing, and what is informing our process for prioritization? So that, let's add that to our list of upward management that hopefully we can push on that. Dr. Bennett, I want to come back to you.
Thank you. It's the end of the fiscal year. That's the goal date.
The end of this fiscal year. Okay. And in my last minute, does DBH currently have the authority to recommend I'm not going to ask that question. Sorry. I'm actually going to yield my time just as I make sense of some of the questions that we have already asked versus those that I wanted to target. Are we going to have another round? Okay. So I'll give back my 20 seconds.
I appreciate that. Dr. Bennett, just to follow up, you said the end of this fiscal year. We just started a fiscal year. So are we talking September of 2024?
It's being worked on, but I believe having it officially designated that people can actually apply to would be the end of the fiscal year. So September 2024.
Okay. I just want to ask clarification on that. I do want to highlight something though, in terms of some of the comments that you made, Councilmember Parker, around the intersections that we're seeing in some instances of overdoses and other related crimes. And, you know, Dr. Holman, this is very valuable. This, for those who can't really see it, it's a map. It shows where all of the suspected overdose cases are.
I'll send it to you in color next time.
That'd be great. In grid form, you might have already sent it in color, but you know, color ink is hard to come by sometimes. Nonetheless, MPD should have this information. And I say that because, you know, at the same time, we were having conversations, particularly this week, about open air drug markets. If they're going to target their particular resources around where things are happening, this provides granular information around the users. Not to say we criminalize them, but they're getting it from somewhere, and it's usually in that neighborhood, and there's usually something that's happening there. I do want to, oh, yes.
The map that the heat map of where the overdoses is happening happens from an epidemiologist at the Department of Health, who sends it to all of the Live Long DC members, of which MPD is one.
Okay. That's the thing. We get lots of emails of people sending it to places, but does it actually get to the individuals who need it, right? So if it's one person at MPD who sits on Live Long DC, are they disseminating it down to the various districts and commanders? Because this could be very valuable information. Now, although I probably could talk to any commander and they can tell me exactly where they're seeing the overdoses happen in their particular area. But this is something I've talked to the chief about, is like, there's an intersection here. Rising cases of opioids, rising cases of violence and crime. Not calling it correlation, but I'm just saying they're closely related, and we should probably be working in concert on some of these things. I want to talk a little bit about education, because that came up with some of the public witnesses in terms of how do we inform, how do we market, how do we provide some public information about this. Dr. Bennett, I know that there was for Children's School Services was going to be doing an naloxone training for all of individuals who work in the health suite. Has that happened?
Yes, it has. And let me get you the number of people they've succeeded in training so far. They are working with all 117 DCPS schools, as well as the charter schools. And let me get that number. They have trained, I believe, all the staff, but yes, it is all the staff.
Okay. Have we made that type of Narcan administration training available to the teachers and administrators at public and public charter schools?
I don't know if they were required to take it, but I think it was.
I don't believe they're required, but this is what I'm saying.
Available.
We often get complaints from teachers who believe that their professional development days don't mean much. This is an excellent opportunity for collaboration where DC Health, DBH pushes in on these professional development days and just train all the teachers.
So it's, I don't have specifically whether the school staff who are trained were teachers versus other school staff, but it's
Okay.
been over 300 school staff in addition to the health suite staff.
Okay. I think that we should sort of just get this number up, right? I carry Narcan in my car. Dr. Bazaran, I'm sure you carry Narcan in your car. Dr. Bennett, you've told me that you've used it while you've been out. Dr. Holman, you carry it. We have some at home. We have some in the office. I think it's especially important when we talk about how we're seeing sort of rising cases happening among young people. I don't need teachers to be nurses. That's not what I'm asking. I'm not asking them to be health administrators, but if you're seeing a child and you or something is off, instead of just saying going to the nurse, I want our teachers to feel empowered to respond, or to at least acknowledge, wait, this is not normal behavior. No, I'm not going to call MPD, but somebody else needs to evaluate this young person. And so how do we sort of push in that way? Because one of the things I think is a excellent idea as we talk about sort of getting some of this education into the schools, not just about Narcan, but just sort of what we're seeing in overdoses altogether, is that I think almost every high school has some teacher who teaches health class. The health people they should be gathered together on a professional development day for a briefing about this. Because I don't want to legislate curriculum. I think our curriculum should be nimble enough, particularly on the health side, to just respond to what we are seeing on a day-to-day basis. Put in a unit about drugs. Or if you already have a unit on drugs, let's talk about some of these other things. So I'm throwing that out there. I don't know if I take that to the opioid working group. I'm not sure if DCPS or the public charter schools are members of that. But I think that is one thing of like, okay, we're recognizing an issue. We're going to take you on your professional development day that we've already paid for with your administrative premium. You're going to come here instead of going there. And we're going to talk about this and how you improve your teaching for something that your kids are facing today. Thoughts on that, Dr. Bazaran or Dr. Bennett?
Both of our agencies work very closely with the schools, and we do updates on information that they need. I don't know specifically about what was done on the opiate front, but I will find out for you.
Okay.
I do take it as part of our role to make sure that the health information that they're giving is up to date and is valuable. The many changes in the picture of substance use and the drugs that are available, I do think it's something that teachers probably have a hard time keeping up with and what that means. But we are in constant communication with them. So that is not something that would be a huge barrier to implement.
I actually think that the teachers might be informative in terms of what the kids are talking about, right? I think we just learned about, I learned about a new one, boot. She said she thinks it's meth and something else, but like, you know, the teachers might know. And for whatever, again, the coordination, collaboration, I'm a classroom teacher. Who do I tell that information to? Do I do a cold call to DC Health? Do I do a cold call to the public health lab? I just post it on Twitter and hope somebody sees it. Like, I think this goes to the question around, do we have a single site where someone can go to find information? I know you'll say, Dr. Bazaran, well, the Live Long DC site. Does the Live Long DC site have HIPS's information on it to say, like, if you find a needle or something, this is the number to call?
It has information on services, supports, and information. And one of the things that we're doing right now is we've been working with our youth program, our youth substance use program, and they are actually developing a public education campaign that was really designed by young people to get information around opioids and other drugs out to young people. I had an opportunity to look at the draft last week that is really moving forward, and it's really looking at what happens if you decide to use a drug and what the impacts are, and what are some other options if you have traumatic experiences or stressors or what have you. And so it's like, I think that also will be helpful, and it will be not only on our website, but also placed throughout the community.
Okay. So it's the draft that you're looking at is marketing
It's a communication marketing
plan.
activity. And we had young people actually work with my staff to determine what the messaging needed to be, what would get to young people, what information they needed.
Okay. And so how will that be disseminated?
Pardon me?
How will we get, once you approve the plan, or whoever approves the plan, how will that get out?
It will get out, our communications team will push that out. And it will also be posted on our website, certainly, and when I say push it out, I mean to the community at large.
Okay. I'm interrogating that because I'm learning from Gen Z. They're never going to go to your Live Long DC website.
Mhm.
They're not.
No.
And so I tell my staff, I don't do TikTok, but my intern did. And, she, of the age, my staff, she's of the age. If we are doing all of this and we're spending all this money, yes, we're talking to the young people, but then we say we're disseminating it on a billboard or at a bus stop.
Well,
that's not cracking the.
Yeah, but young people do look at social media, and they can
traditional
get this
forms.
information.
Does DBH have a TikTok account?
I don't know if we have a TikTok account.
Okay, because they're not on Facebook no more.
I don't know but I do know that we do tweet, and we do have Facebook and some others, but I don't know if we have a TikTok account.
Okay, Councilmember Barker,
I simply don't.
Can I just continue on this for just a little bit long? So, in the budget earlier this year, one of the things that the committee funded was a pilot for peer-to-peer specialists, or peer-to-peer educators. Yes. This is an excellent little army of individuals to help deliver, but where are we in that grant writing process?
The scope of work is in development by our child and adolescent team.
Do we have a
target scope of work? Yes.
Do we have a target date on when that is going to be made available?
I don't have a target date, but it'll be soon.
Okay. Do we have a target date on when we're going to get the money out?
Pardon me?
The money.
The money will flow when the RFP and the solicitation has been approved. It has to be. It'll be competitive.
I understand that. And I said this to you in my office, and I just want to say it publicly for all of our agencies, because all of you have grants. The idea that we don't start writing a scope of work until October 1, when you know that the money was approved months before, is a problem. Because here is a peer-to-peer program. If we don't get the money to the agency until the summertime, what good was it? Can we at least make a goal that this is something we can get for second semester for high school students? That the money will be out the door and we will start second semester. That's what, January? I haven't been in school in a while. January. January?
Okay.
Okay. All right. We'll follow up at performance oversight in terms of where we're going with that. I'm well over my time. Councilmember Parker.
I will not use all of my time, but I want to thank you all for sharing. I imagine for each of your respective agencies, there are many priorities that you're facing. So I'm trying to get at this in a different way, since we won't say that we have a public health crisis involving opioids. Can you just kind of rank the top 3 issues for your respective agencies in general, and where opioid deaths fall in that ranking? So for instance, for DC Health, what are the most important things facing DC Health in the district? is opioids, or are opioids even among that list of top 3 things?
Absolutely. Our basic mission is to keep everybody alive and well. And so if you take that as the mission, this is one of the largest threats. It is also one of our more stark disparities in terms of death rates and the emphasis on African-American men in their middle years. So it is absolutely at the top of my list, along with heart health and some other chronic disease issues.
So it's safe to say that at DC Health, the opioid crisis is at the top of the list in terms of the priorities of that agency.
Our role is not as primary, but I've
Yes.
already gathered my staff together to find out how can we coordinate better within our internal resources, which resources are we sharing, and what are those relationships like? So
Love it.
I've been here 3
That's
months,
music
it's
to my
already been on my
ears.
list.
We can't call it a public health crisis, and perhaps politics colors that and informs that. I'm not saying for you all, but others. So I'm glad to know at DC Health that this is a main priority. Dr. Bazaran, I'll ask a similar question. What are the most important issues facing DBH, and where does this issue fall?
Well, certainly opioids. Also, transformation of our system, which will result in the carve-in of behavioral healthcare services into the MCOs. And that's important because we want to move to whole person care and be able to have a coordinated approach to providing services and supports. We know that many individuals with substance use disorders also have chronic physical health conditions and mental health conditions. And right now, those services are fragmented. And so we want to so that's a big priority. The other one is school-based behavioral health. And I think that, we want to make sure that we get services to young people where they are. And the school-based behavioral health program and that expansion is one way to do that.
Thank you.
Certainly, responding to opiate use disorder is a priority for us, but because we have so many successful reversals, and yet we are faced with because we're EMS, trauma, which also mows down young people. We're really focused on trauma as well, even though something like stroke and is a bigger number, but that affects an older population. So if you're talking about the overall devastating impact against young people, I would say it's both trauma and opiate use disorder.
Thank you. That is really helpful. I will certainly follow up with each of you to take you up on the offer, and I'm gonna take it as an offer to work on the ground in Ward 5. And as much as you're willing, as much as Councilmember Henderson is willing, and I know she's an at-large council member, and she's been very willing and supportive of, leaning in on the issue impacting Ward 5, I think we can make a difference. And there's already work happening to just kind of come up with strategies and approaches. And I would love to plug you or someone from your respective teams in on those things. So I will follow up there. Just 2 things I wanted to get to. We heard public testimony earlier around a campaign or a broader strategy. Councilmember Henderson was talking about that. How are we reaching young people, but all people? Dr. Bazaran, can you speak to the vision for a public education program to emphasize the threat that is out there with opioids and fentanyl and the like? And I know there are radio ads, and I know these things exist. How are we thinking about enhancing that, improving it, making sure we reach people like those on TikTok or those that are not necessarily benefiting from the current educational program?
Well, I think, are you talking about delivery, how we deliver the messages, or are you talking about the message themselves?
The message, a campaign,
Yeah.
awareness. How do we build awareness? Because I don't know if the city is aware of the crisis that we're in. Certainly the community is most impacted by by this is,
Mhm.
you know, they are aware, but the individuals that are concerned about crime, if they were more aware of the opioid crisis we had, maybe people would start connecting the dots
Mhm.
and leaning in towards real solutions for care. So just
Well-
how are you thinking about enhancing the public
Well,
awareness
as you
program?
know, we've done the Be Ready campaign, and now is the time campaign for those individuals who you know, substance use disorder is a chronic relapsing disease. So we know that people will move in and out of recovery. And
Can I
so,
ask this? I'm gonna make it easy for you.
yeah,
Before we get to the budget cycle next year, are you able to detail a vision or request for how we enhance our public awareness program in the
oh, sure,
district?
yes.
Yes, okay. And I know last time you testified before the committee to say, you know, the agency had everything that it needed. Even when it was clear there were some gaps. Again, I understand those tensions, but if you could deliver that, I will commit to fighting and making sure we work towards getting that in the budget. The last thing, I wanted to just circle back on the concrete commitment around data sharing. So Dr. Bennett, thank you. It sounds like within the week, you're gonna deliver that data to us.
To you, yes, that data, we looked and it is already posted.
Mhm.
So
Where is that data
it
posted?
is
It's on the website,
on yours.
Which
on the Live
website?
Long DC website, the non-fatal overdose data and the ward level data.
And is that up to date?
Yeah, I think, when was it last posted?
Or a better question is,
The
when was-
last 2 months, within the last 2 months.
and do you have more
More
recent
frequent
data, Dr. Bennett?
I believe our turnaround is more frequent than that, but let me,
Mhm.
So my request would be, Dr. Bennett, if within the next week, if you're able to share that data with us. And I have not checked, but I'm sure the team here is checking. I'm assuming that data will continue to be posted publicly. Is that accurate on the Live Long DC page? Okay, great. Well, as promised, I'm going to give some time back. I again wanted to thank you all for your testimony, but also thank you, Dr. Bazaran. This has been a tough week for Ward 5 neighbors. And I think Dr. Bazaran and I have been on the phone no less than 24 times.
Yeah.
And so it does not go unnoticed. And I really
Thank you.
appreciate it. Thank you.
Councilmember Parker,
My
before you
pleasure.
go, I'm going to follow up on something with Dr. Bazaran that we collaborated on during the budget, which is a targeted outreach pilot, which included a location in Ward 5. What's the timeline on that grant, Dr. Bazaran?
It's, here again, the RFP is being developed.
Okay,
So we'll
January?
get it out as soon as we can.
okay. You,
I think that's,
the part that makes this difficult is that we'll start in January,
Mhm.
and then I get the budget in March, and then I have to make a decision of whether or not I fund it again, but I don't even know if it worked because we didn't even get started. You see my struggle? I hope you could just appreciate the struggle that we have in terms of the timeline piece here. But let me ask this. We already fund certain targeted outreach, right? We have contracts with HIPS, we have contracts with Family Medical Services. Are our contracts nimble enough to request that they target a specific area?
yes, and as a matter of fact, yes, they are. They're nimble enough to target areas. And for example, one of the things that Dr. Bebout is here with us today. And so if we need outreach in a particular area, particularly because of a crisis, we can move pretty quickly to that area to provide it. In terms of the opioid epidemic, we do fund several outreach teams through the opioid epidemic, and we can certainly make adjustments as
Okay.
needed.
So I know that his team has folks out and they go out in the terms of crisis moment where it's sort of an active something has occurred.
Mhm.
I would suggest that what is happening on North Capitol Street between New York Avenue and Florida is crisis. It may not be an active something, but let's see, I know DC Health, your office is on North Capitol. So I know your staff passes this area. Some now has a new building there. And I don't even, it's a combination of things, right? I have unhoused folks. I have folks who are experiencing crises. I have a childcare center that's on North Capitol who like literally emails MPD and us every week about individuals in front of the door of their childcare center experiencing drug use and overdose, et cetera. And yet when I go through that area, I see no one who looks like DC government, except for FEMS when there's an overdose, who is doing anything. You got Mundo Verde fentanyl on the playground that is being picked up by pre-K students. Like, at what point do we say, all right, y'all, crisis? I don't know if it's his team. I don't know if it's HIPS. I don't know if it's Family Medical Services, but it's saying, okay, for the next 2 weeks, we are going to target this particular area. We're going to have boots on the ground. We're going to talk to people. We're going to try to move them into treatment. We're going to see if they're not connected with services. We're going to put them in services. Do. And work it out with MPD that there's also, if there is a issue there, that we have that part. I hate the idea that all of these businesses are having to hire private security or their own individuals to do outreach when the government should be doing the work. Can we put some focus there? For starters, I'm not saying that that's the only part of the city that's not a problem, but today, this week, that's a problem. Who do we ask?
In terms of whether or not we can deploy outreach teams, and we do, to areas where there are issues that are involved.
Right.
Yeah.
Like where would we bring that to? Do I bring it?
You can bring it to me.
Okay.
Yeah.
And then you will call DC Health and FEMS and MPD and and DHS.
Certainly. Yeah.
Dr. Holman?
And the way our system works, obviously you've seen our units there called by 911. Our street calls teams follow up regularly where there are hotspots that are active, and that's an intersection well-known and well-trod by our street calls team. And they coordinate with the crisis team at DBH all the time to walk boots on the ground and follow up, talk to the bystanders, try and engage them in harm reduction strategies and the like.
Okay. Do we talk to the businesses that are in that area too? Or the homeowners or the renters?
If they are bystanders, yes, but not, I don't think we knock on doors of private residences or businesses. No.
Okay. I think this is, as we think about our strategy around targeted outreach, we got to do something different, but also recognizing that the public thinks all of this is happening and DC government doesn't care. And I'm saying government, not just the council, although we get a lot of the brunt of it or whatnot. But in Ward 1, 2 weeks ago, I had a woman who owns a business there. She emails us, someone overdosed on her front steps. Calls 911, that's great. But then what is the follow-up that happens with the rest of the block? Because now she's posted this on the listserv. And now everybody else feels like, oh yeah, that happened to me or that happened to me, and nothing is happening. They don't see the on the ground work around, yes, we have people who are overdosing and dying in their homes, but there are very much a lot of people who are overdosing and dying in the streets, not in alleys, but in arterial corridors. And they don't see that part happening. Is this a DMHHS question, or is this like, I'm trying to understand who brings all the agencies together to say, and we're going to do this. We're going to blanket North Capitol from Florida to New York Avenue. We're going to spend a week to try to stabilize that corridor. And then MPD is going to follow up and make sure that it stays consistent.
I can certainly take the lead in doing that. We work very closely with our partners around it. This would be more of a targeted outreach kind of activity.
Okay. Can I ask that this be something that's on the agenda for the next week?
Go ahead.
Or Dr. Holman?
So our street calls team has done outreach, community outreach with DBH in response to high density overdoses, where they walk the streets, knock on doors, and talk to everybody that they can.
Okay.
It's based, we do that with fire prevention as well. It's kind of a all hands on prevention model for us.
Yeah. Okay. I think that's when we talk about targeted outreach. I don't know if it's just ads at this point, but it is also a certain level of visibility in terms of like the work that is happening and what is going on. In that same vein, and Dr. I want to acknowledge that the data that you talked about, Dr. Bennett, is on the website. It's a new it's been recently updated. How often will that data be updated? And I don't actually know if it came from you, because what we're looking at has Department of Behavioral Health's logo on it. Okay.
The updating of it is not a DC Health function, but the data comes out to be available, I believe, at least once a month, but let me double check on that.
Okay. Because I think the date for the data up now is September 28th. So I'm curious of like, okay, is this a monthly update or is this a quarterly update?
No, we update every 2 months.
Every 2 months?
Yes.
Okay. Is it possible for us to update every month?
I will ask my team
Okay.
how frequently they can get it out, and we can look at what are firming up the connection.
Okay. We have a running list of follow-ups, so we'll go over that at the end. One of the things when we talk about sort of a single site piece, the website looks very nice, but I don't necessarily know from a usability function whether or not it responds to why someone would have gone to that website, right? So somebody might have gone to that website because a crisis just happened and they're looking for help, or go to the website because they suspect someone in their lives might be dealing with sort of an addiction, et cetera. Is it possible to put like a FAQ? Frequently asked questions around, you found needles on the ground, what should I do? Can you go to the website, please?
The answer to that is yes.
Okay. Okay. I think it might just be, you might have the information on there, but it is not necessarily in a way for the public to know, right? So if I go to the resources page, we listed out in terms of prevention, harm reduction, et cetera. I know what harm reduction means. I don't know if everybody else knows what that means. And so then you have to click through every tab to kind of understand, maybe, is this the category to answer the question that I have, which I'll just use, like, we have needles, what do we do? I will say this, for the committee, we got a call from a school that said they had needles on the playground. We had to call you guys to find out what is the number that we call. So if we had to call you, then I wonder what, like, someone from the school, what would they have done? And then how quickly do we respond to that call? Because if they call 311, embarrassingly, 311 will say, it will take 7 days to respond to this, because that's the automated response that we give for certain calls of service, right? Like of things, where in that case, the school is like, well, I'll just send the custodian out to pick it up, so I don't have to cancel recess this day. That's not safe. That's not properly disposed of. So I think we just need to think about if the level of drugs on our streets or the overdose is, I'm going to call it a crisis. I don't know if you can call it a crisis or not. I don't know what, the talking points say, but our strategies for the public should look as though it's crisis. So we're directly saying, I don't want people to call 911 when it's not involving a person, But if it's involving a substance or a certain type of paraphernalia, they need to know, do I just put this in the trash can and hope for the best? It's not safe, I don't think, for the DPW staff on the other end of it. And so if we can just do some tweaks and adjustments, and maybe I'm sure you guys have certain groups of members of the public or community-based organ, just a focus group your website. Does this work? You do that with young people too. Focus group the whatever. Are you planning? Well, you worked with young people on that. So like, I just kind of want to put that out there. I do want to bring up, and Ashley, you can stop the timer because I'm not sure if any of my other colleagues are coming, but I just lost my train of thought 100% where I was going. Oh, yes. No, I remember. Okay. Someone from the public, I think it was Michael Pickering, brought up the question of a dashboard. And I think we've raised this before. Have we made any movement towards a comprehensive look at who has beds available in real time?
One of the things that I've done is to require that all DBH providers use and be connected to our health information exchange, which is one thing. So information can be exchanged quickly. The other thing that we are looking at is the development of a bed board. I strongly suggest a bed board, and I actually have tried to do it before. And here again, a lot of it is that there may be some resistance from providers in terms of saying we have X number of beds available and so forth. But
push back on transparency?
But that's one of the things that I do support.
Okay.
And would like to move forward, because I think that it makes a lot of sense so that you know specifically where it is. We do have that ability within Access Helpline, within our constellation of providers, to know where beds are located, but it's a broader issue. It's a much broader issue.
Okay. For the bed board idea, that's something you could do administratively, yes?
What do you, well, it's more than administratively.
By that, I mean, it does not require legislation.
No, it does not require legislation.
That's what I mean.
Oh, that's right. Okay.
Yeah, that's
yeah.
The agency can take care of it without any additional things.
Oh, I'm sorry, Dr. Beba? He's working on the bed board. That's why.
Oh, okay.
He's coming. Yeah, go right ahead.
Okay. Oh, sorry, we took the fourth shareware.
That's okay.
If you just
He's working on it. That's
just
fine.
introduce yourself for the record.
He's working on it.
Richard Bebout, Chief of Crisis Services, DBH. I just got an update since it was raised this morning.
Okay.
We signed a contract with a vendor to work with us on updating our internal electronic health record. It has the functionality to do a bed board, and we expect to do that, but begin that work in December.
Okay.
The complexities that Dr. Bazran alluded to have to do with hospitals in particular, sharing information in real time about bed availability. But I think it's a different issue, and we're confident that we will have real-time data. We do it the old-fashioned way today in terms of calling every day to determine what beds are available at different residential substance use disorder providers. But it will be modernized by the early next year.
Okay. I think obviously calling every day is something you guys have to do for today, but it's
Right.
highly inefficient. And I mean, the hospitals have to provide that information to FEMS. So if they get bed information, why couldn't you guys get bed information?
Well, here again, we're looking at how to do this across the system.
Yeah.
And as I said, it's something that we support. We've been working, Access Helpline can do it within our system, and we've been doing that for years within our own system because we have control over that.
Okay.
I've said we got to have the data, and so of course we do. And we are now working not only to upgrade that, but also to expand it across the system. And that means, it's a collaborative process.
Okay, we'll check in on that during
And
performance.
Certainly our DC Health partners are a part of that process. And so she
I
may
actually
want to talk
think
about
that something like this could benefit hospitals, because I often, when I meet with the CEOs, they'll say, I have somebody in my emergency room who doesn't need acute care anymore, doesn't necessarily need to be admitted. But if I want to refer them to future services, I have no idea who has space, I guess, or they call Access Helpline, or they call somebody, there's too many steps to the process. Dr. Bennett?
There are efforts within both the health information exchange and just the hospitals talking among themselves to look at how the data can move, in particular around referral. There has been significant development work. I don't have a timeline, unfortunately, on how much of that will debut when, but letting providers, in the same way they look up somebody's past history, also make referrals or look at where referral agencies are, is an ongoing plan. I will have to get back to you with details about how far that has gone.
Okay. Is that within CRISP?
Yes.
Yes.
Thank you. Dr. Bazar, I want to ask a little bit about how we evaluate what we're currently doing. Not just with you, but also in terms of, I'll ask DC Health too. Because I know that there are some grant programs that DC Health has that may not be directly related to substance abuse, but there might be some tiptoe over. And then Dr. Bazran, yesterday, you presented a slide to the commission that sort of outlined all of the federal grants that we have around opioids. I think you said about 50 million, if I'm around $50 million. Okay.
That's correct.
So the parameters for those federal grants obviously come from the federal government. And I imagine there are some annual reporting requirements.
That's correct. In terms of an evaluation, we have to have an evaluation component.
Okay.
And so we do have to collect data on the degree to which we've met the goals and objectives that are included.
Have there ever been instances where we haven't reached the goal or objective?
I think there are times in which we have not reached it, but there's a reason for it. I mean, it could be any of a number of
Okay.
reasons, but we do have to provide that justification for the project officer's review.
Okay. And I'm asking in sort of a semi-skeptical way in terms of that, because I know from, past agency directors, even in this government, when we talk about, say, key performance indicators, sometimes agencies set key performance indicators that they absolutely know they can meet, as opposed to stretching in terms of ambition around what is the actual need for whatever we're trying to address. And so are the objectives and goals something that we set internally, or are the objectives and goals set by, say, SAMHSA or whoever the federal agency is that provides?
I think it's a combination of the two. In some instances, SAMHSA has specific benchmarks that you have to meet. In other instances, it's dependent upon what's going on in your community that you need to set. In terms of our KPIs, we have provided stretch goals in our KPIs. I can give you an example. For example, one of the things we wanted to look at is the degree to which there is follow-up when somebody steps down from an institutional setting, which is a hospital or residential setting, within X number of days. And our staff actually looked at the data, and we had to make some changes in our process so that we could begin to improve. And so if you look at our dashboard, you can see that there has been change over time, and we track that as an executive team on a monthly basis.
Okay. Dr. Holman, I'll ask this to you as a medical director who, I think of all of the three agencies, you're the staff who works at FIMS uses Narcan the most. As the drug supply in the district changes, do we feel like Narcan is still our best tool?
So it depends on the clinical assessment.
Mhm.
If the patient has stopped breathing, we don't focus on the Narcan so much. We focus on the resuscitation efforts.
Oxygen.
Oxygen.
Well, or CPR,
Or
whatever's needed.
Okay.
And so that's what we focus on, what is needed. And so in a similar way, with the drug supply incorporating more fentanyl over time, we've had to use more fentanyl, higher doses.
Oh, we've had to use more naloxone at higher doses, you mean?
We have to use additional doses for one individual because of the fentanyl. If there's fentanyl on board, which there has been in many of these cases lately, the dose of Narcan needed for reversal
Yeah.
effect is higher.
I see. Okay.
It's not one spray and you're done.
Yeah, I think Mr. Jones yesterday talked about how he had to use 6.
Yeah.
Which I guess I'm trying to
And Dr. Chapman addressed that earlier today as well.
right. I guess it's sort of like, what is our feedback loop with even, I don't know, the companies around what we're seeing on the ground versus what they're providing in their dosing and packaging?
So as Dr. Chapman mentioned, the FDA has approved a higher dose, and we've been thinking about incorporating that. We haven't made that move yet, but
Okay.
we're going to follow our data and our experience to guide
Okay.
us in that decision.
Okay. I think that I'm glad to hear that that's one of the things that we're sort of tracking, because one of my concerns, especially as we have more people who are mixing things, is that naloxone will be rendered ineffective because you've put a concoction together that is not designed to reverse.
And that's quite true with the xylazine that's been seen frequently in our.
Naloxone does not work against xylazine.
No.
Okay. I feel like this is also part of the education piece too that is important, right? I don't even know if it's like some basic stuff of like the xylazine, it doesn't work on. Fentanyl is colorless and odorless, so it could be in anything. Yes, you can use a fentanyl strip, but it'll tell you about the presence. It won't necessarily tell you about the potency, nor will it tell you how your own body makeup and whatever else in your body is going to react to it. Because, for some, it's in there, but it's only one pill. And then we saw what happened with the young woman, right? In terms of that, how often do we communicate with federal agencies around what's happening in terms of opioids here in DC?
I will look to Dr. Bennett to answer that perhaps, or Dr. Bazran.
We meet as a region, actually, with our regional director from the Substance Abuse and Mental Health Administration. And we talk about what's happening locally, as well as what's happening in the surrounding states. And the reason for that is because we know that the drug patterns, if a drug shows up here, it's going to eventually be down there. And then we talk about the strategies that are being used to address it. And that's a monthly meeting that we have with our substance abuse leader, our regional leader from SAMHSA.
Right. With that meeting that we have with the regional person, do we have conversations with, or do you all have conversations with your counterparts in Maryland and Virginia around what they're seeing in their jurisdictions,
Yes.
particularly Montgomery County, Alexandria?
Right. Yes, we do.
Come frequently.
Okay. And what has come of those conversations, right? Are we only thinking of this crisis from a DC standpoint versus a regional? Obviously, our numbers, like if you take the state of Maryland, for instance, their numbers will look very different if you look at it statewide. But if I look at the county, it's possible that PG is facing very similar numbers that we're seeing. But when you add everybody else in, Maryland doesn't come to the top of the list because the other counties sort of balance it out who are not necessarily facing that. Like, are we talking to the medical directors for PG County, Montgomery County, Arlington County
there's a lot of regional coordination around this and other issues, both as a group of different health agencies and our other different federal agencies as a region. So yes, there are multiple opportunities to talk about this issue.
Okay. But when we talk about the issue, I know we're sharing data. We're perhaps talking about what drugs you're seeing, but are we talking about, hey, we tried this and this has been working, or hey, we tried this and this was like a failure?
I can.
Yes, that is part and parcel of what we're doing as we're having those conversations. The other thing is that we also have conversations with NASDAD, which is the national organization that is responsible for substance use disorders, and brings a lot of the current data to us as commissioners regarding what's happening in different places around the country. So there's a lot of information, not only feed in, feed out, but also what's worked. And what have you found is really a best practice? And what can I share with you in terms of what we're doing? And then how can we come and visit you in terms of other things? Like, for example, we've had other places reach out to us because we've done such a good job on naloxone saturation. So what did you do? How did you do that? How's it working? That kind of thing. And then we have also shared information, for example, regarding what does a sobering and stabilization center look like, and what are the results, and what should we be thinking about so that we can adopt that as a practice within the district. So there's a lot of that.
Okay.
And I would just add to that I confer with a group of the 50 largest municipalities EMS medical directors weekly. And so we share common challenges and best practices as well.
Okay. I think that's all good to hear. The only thing that kind of gives me pause is that when I talk to my legislative counterparts in other jurisdictions, say, oh my gosh, it's so great that you guys have vending machines. We could never do something like that in our jurisdiction. So in some eyes, we look cutting edge, and yet, and perhaps we are in terms of our ability to do some of these things. And yet our numbers aren't reflective of our innovative efforts. That's the part that is kind of flexing.
I'm just going to give you an answer that we have data sharing agreements from epidemiology with 31 different jurisdictions. So we do go back and forth. That is my hope for what we're talking about in the opioid abatement group, is that we will be, and you were there yesterday, that we'll be talking about what's most effective so that we can move forward. All of the different interventions that are done need to be looked at in terms of which ones are the high impact, so that we can scale. There are always restrictions, even here, on what can be done, but there are practices that have been tried in other places, and some that we have tried here that can be scaled or expanded or moved to one area from another. So I do think there is a lot of work to be done in terms of the strategy around this, but I think we have the opportunity to do that because we have a funding source and a group of people who are interested.
Yeah.
And I think we do have data on what's working and what's not working as well that we can build on.
Okay. How can we share some of that data in terms of what's working, what's not working?
I think that we can share.
I don't necessarily think we need to put it on a public website, but I think between us, go ahead. Yeah, no, go ahead.
Well, I think through, for example, through Live Long DC, we do share that information and do come up with new suggestions. And I'm really hoping that as we present data to the Opioid Abatement Advisory Commission, that commission will also have an opportunity to look at it and to explore. And we can also do the research that's required if other ideas come up.
Okay. Live Long DC is a coalition, a task force too? In addition to the framework, there's a group of people, I'm assuming.
Oh, yeah, many people. It's really I would describe it as a community movement. I mean, there are people from all sectors. We have literally hundreds of people who are involved in.
Okay.
DC.
How often does that group meet?
As a matter of fact, it met yesterday. It meets monthly. Mhm.
Okay. Are there minutes? I'm going to ask that because I don't want to ask you a question that I can go find.
Well, I
in a
think
response
that we
to.
did present the minutes in our response.
Okay. Okay. Is one of the things that I'm trying to get to is you said we do present information on whether or not a strategy has worked or not. And I'd just be curious what some of those findings said or not. One thing I did want to ask around sort of the federal question, to what extent are any of our agencies helping to intervene in the gap or provide some additional support around conversations with the federal government around MAT, medically assisted treatment, and some of the issues pertaining to that, whether it be prior authorization, whether it be the limits that for dosing. Dr. Chapman talked about this a little bit earlier, but I also know from for some of the folks at Howard, they feel like they're out on this island alone. They're doing the research to talk about some of these things with buprenorphine and all of these other things. And yet, because there aren't other universities who are focusing on this, or because there are no other conversations about this, they feel like it's not getting heard and perhaps could use some backup from government officials while talking about some of these things.
I think one avenue might be the National Association of State Drug and Alcohol Abuse Agencies, and that it has not come up yet in NASDAQ as an issue.
Okay.
But it does involve every state in the union, your representatives there.
Okay. Is that something you could bring as the representative of DC? Okay. 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 I am the commissioner here. And so, yes, I can bring that. And I am a member of NASDAQ. Okay. If you just give me just a second. Dr. Bennett, I think you're new on the team here. And I don't think we necessarily talked about this at your confirmation hearing, but I'm interested in terms of your experience from San Francisco. The San Francisco Department of Health had everything in terms of all the various pieces, and also had components related to opioid and substance abuse. And I know from, I guess, just even reading the news that this is something that San Francisco has certainly struggled with. Are there knowledge or strategies you've gained from your experience there that you think we should be exploring here in the district?
First, I don't know that I know absolutely everything that's being done in the district, so I don't want to say something that is already being done. I do think there are always things that we can pull from other places. Being able to coordinate on a frequent basis between not just the leadership, but also on the ground level so that the staff are actually thinking of themselves as a team. I think that's a direction that we do to some degree, but can probably enhance. And then being able to have more publicly available information is, again, a place where we're going to. So we're moving forward on some of the things that I would suggest. They just aren't completed yet. And there are more. We should think through what's possible in a differently organized system.
Madam, if I might, I actually visited San Francisco early in my tenure. to look at some of the information and some of the things that they were doing. And one of the things that I looked at when I was even in Maryland is their stabilization and sobering center. And we actually used a lot of that information to inform the process of what we were developing here. And so I think that we do go to different places and try to extract the best information. A lot of those things are captured in either the fugitive literature or the formal literature, and then we kind of deploy to go get it.
Okay. On the stabilization sobering center front, big news for next week, which is great. Is it going to be operational, as in like, will FEMS be diverting calls there starting next week as well?
As soon as it's open. Oh, I'm sorry. As soon as it is opened.
Okay.
Yes.
Okay. All right. So by January, February, we should have some idea of how things are going and all of those various pieces. Okay, great. I don't have any further questions at this moment. I know that the Opioid Abatement Commission is meeting in November again. And I can appreciate Dr. Bazar, and I didn't say this yesterday. There are a lot of people on that commission around. I appreciate the sense of the decision not to wait to hold the next meeting. And not to just go with, oh, well, the legislation says we need to meet quarterly, and so that's enough. I will say this, I think the rising overdose rates and the intricate web of challenges, some of them we've discussed today, certainly suggests to me that this is a crisis. I think it certainly suggests to my colleagues that this is a crisis. And to the extent that members of the public are informed of what they see in their communities, they would also say, we have a problem here. That being said, it feels as though folks don't feel like we have a clear direction in terms of like, okay, and here is step one of what we're going to do, and here's step two of what we're going to do, and this is how we're evaluating going forward. And I can appreciate that we have a lot of information, we have a lot of experts and people who are meeting, but how we translate what happens in meetings to what is happening on the ground, I think is where we might be having some pieces. And I might posit or suggest for the next November's next week, November, December, for the next 2 months, that perhaps the opioid working group across the government should be meeting more than once a month and sort of developing what is the strategy to ensure that the numbers for FY24 don't look like the numbers for FY23. And I don't know what that looks like, but I see the numbers and you say, well, we meet monthly. And I'm like, well, I know this is a everyday occurrence. We are all living it every single day. We're looking for a little bit of movement here. So I want to thank everyone who contributed to today's roundtable, the public witnesses, and then of course, all of you. On this, it was on the resolution, but it's also a little bit of oversight. It's council, you're here. We're not going to not ask questions on certain things. For anyone who was not able to attend and speak at today's hearing, we will accept public testimony until November 9th at 5 o'clock. You can submit them written testimony online on the council website. You could just upload it right there, or you can email it to us to Ashley Strange at astrange@dccouncil.gov. You can also leave us a voicemail, although I highly suggest you put your full thoughts in writing, as it's easier for us to transmit that for the hearing record. If you leave a voicemail, please remember to speak slowly and spell your name for the record. For those in the public, I'm going to move that this resolution be included on the agenda for the council in November, on November 7th. I think we had unanimous sign on, so I imagine that this will be unanimously approved, and then we can continue the conversations with the executive around what happens next in terms of that. But there being, I think there are a couple of follow-ups, some of it pertaining to data, and Okay, so the non-fatal overdose data that's already on the Live Long DC website, we're asking a question of whether or not it could be more than every 2 months that it be updated. And then an additional request in terms of that data. So the data that is posted in terms of non-fatal overdoses is broken out by ward. We didn't see an option for us to just see citywide. So if that could be a cut, that is done on that front. And then there are other things we'll follow up on in January when we see you for performance oversight. I'll be asking more questions about youth, marketing, public outreach, targeted outreach. My immediate request to all of these agencies is that we get together about North Capitol Street in the same way that we've done some work in other areas, right? I think Chief Smith calls it the whole of government approach strategy. You did it in Chinatown, did it on Kennedy Street. There are other places we just need to do this in a bit more regular and consistent fashion. With that, the time is 1:54 p.m. and this hearing is adjourned.